Welcome, everybody. Really glad to see so many of you today here. I think we have full house already. This is the Nordic Health Data Summit, and I'm Mikael Rinnetmäki. I'm an expert in Sitra. I joined Sitra recently, and I'll be leading the VALO 2 project. Here we are presenting the results from the VALO project, so the first part of the project, and I'm so excited to learn about what I need to take care of next. And I'm so happy that you have joined me to learn from VALO project. And we are organizing this together with FinHITS and Antti.
Yes, very much welcome on my behalf too. I'm Antti Piirainen. I work at Findata, and we have the FinHITS EU project going on. And I'm just so glad that I get to host this with Mikael, because, even though he has worked at Sitra for just a short time, Sitra is a foresight house. And so last week, Mikael said that, hey, Antti, we're hosting the event. Should we plan a dress code, maybe color coordinate, like VALO is green and black, and what is FinHITS? Well, I said, well, that's like pink and baby blue. I might not have those kind of colors on my wardrobe, and I didn't. But this morning, Mikael was like, hey, Antti, I got something for you. I'll be changing this. Thank you very much. Should we go on to the agenda? So in the morning, until lunch, we have the live stream going on. We'll have 4 sessions. Three first ones are on the VALO project, and the 4th one is FinHITS.
And then we end the live stream, and then we have lunch break and afternoon session only for people on site. And there we are joined by Ministry of Traffic and Communication in Finland, and look at some of their use cases in the later sessions. But before that, still some health data. And throughout the day, we wish that all of these presentations will kickstart some discussions. We have coffee breaks, we have the long lunch break, and we also have the online stream. And there is chat functionality. So if you're really agreeing with something or disagreeing with something and passionate about sharing that, people on site already, please feel free to join the online stream and participate in the chat. Many of the presentations have panels with communication, and then the last session of the morning also has place for audience questions.
Yes, indeed. But without further ado, should we introduce our first speaker or introducer for this day? I'm so glad that so many people came here, and I believe there's a lot of people in the stream too. So please, Päivi, hop on stage. I'll give you a microphone.
And I give you a clicker.
Okay.
And
Thank you. Good morning, everyone. How are we doing today? Good. And hopefully you also enjoy as much as I did yesterday the dinner. Thank you for that dinner also. I'm Päivi Silauke, and I'm coming from the Ministry of Social Affairs and Health, and currently my position is and title is Special Envoy for Health and Well-being. And I'm in charge of the government's health and well-being growth and RDI projects. But my minister, Kaisa Juuso, Minister of Social Affairs and Health, wanted to send you greetings. We really think that the work you are doing is so much valuable that also our ministers want to be involved into that. Unfortunately, she was not able to come here, but she wanted to send her greetings, and let's now get her greetings.
Dear participants, I extend my warm greetings to all of you. I am truly glad to have the chance to share a few thoughts with you today. In Finland, the meaningful use of health data has long been at the core of our health policy. We have a long tradition of registries and a digitally advanced health system. Together, these provide us unique tools to improve care and research. The Finnish health and social care system is currently undergoing major reforms. In this process, data and digital solutions are key to building more resilient and citizen-centered services. The secondary use of health data is not only a way to improve efficiency, it also fosters innovation, ensures better outcomes, and supports evidence-based policymaking. At the European level, the European Health Data Space regulation introduces an important framework. Finland welcomes this initiative and looks forward to stronger international collaboration that it will enable. However, Nordic collaboration is equally important. Within the VALO project funded by the Nordic Council of Ministers, we share knowledge and build common solutions. These themes are central for the Finnish Ministry of Social Affairs and Health, especially during Finland's and Åland's presidency in the Nordic Council of Ministers. Finally, let me express my thanks for the valuable work you do for Nordic Health Data Cooperation. I wish you all an inspiring and fruitful event.
Yes, and also my warm greetings and thanks for your all already the work you have done, and especially for Sitra, who is coordinating the work on behalf of the Ministry of Social Affairs and Health. Since 2014, I have been working with the secondary use of the data, and then we launched the health sector growth strategy. And each government after that has been updating that. And the idea has been there that we have a huge data and quality data registers which give us also insight not only to the research but also how we can improve our whole health system. And having also the trust that our people here in Nordic countries have to our societies and institutions, it's of course really important to keep that, and having that, the data, and then also the technological know-how and the health system that covers primary healthcare and secondary healthcare. Nordic countries and Baltic countries have been then leading the way also in talks of health in all policies, but also towards then from ill care towards prevention. And that is something that I think that now when we have this kind of legislation also at the European level and then the technological know-how, we are suddenly there where we can do the move towards preventive, more timely and personalized care. And I'm so proud that this region, not only in Europe, but globally, is leading the way. So I'm really eager to listen to your presentations and discussions today, and would like to then ensure you that the government of Finland, whole government, not only one or two ministers, but the whole government is behind and supporting this work. With these works, and without further ado, let's begin this day. Thank you.
Thank you so much for the kind words from the Minister of Social Affairs of Health and Health in Finland. And as Minister Juuso said, EHDS is coming and we want to be prepared. And in Nordics, we see that we have a lot of assets that we can take forward. We can even be a lighthouse for the entire EHDS project. And to share some more insights on that, is Markus Kalliola from Sitra. Again, a warm welcome, please.
Thank you, Mikael, and good morning from my side as well. As said, I'm Markus Kalliola, work as a project director in the Finnish Innovation Fund, and I'm part of the VALO coordination team as well as the EHDS 2 coordination team. Both projects working towards the implementation of the European Health Data Space. Well, before I start my presentation, thank you, Päivi, for your kind introductions and also for the Minister Juuso on her words. I think it really raised the importance of health data both in both of your speeches and also the role of Finland in both Nordics and the European scale. So let's start the discussion on the health data today. Of course, to sort of lay the foundations, we have a lot of health data in Finland and probably many other countries, especially Nordics too, but it is unused too much. I think it's too cumbersome still to use it. And that's why we have the European Health Data Space regulation to make it more easier to use for primary and secondary purposes. And as Mikael said, in the Nordics, we have the opportunity to take advantage of this common regulation. The Nordic Council of Ministers in 2019, they had a bold vision that the Nordic region would be the most connected and integrated region in the whole world. And that also lays the sort of the foundation for the VALO project, because then we want to also be most integrated in healthcare sector. And they decided to finance the VALO project to make that happen. I will speak about both the European and the Nordics and present you both the European regulation and also the VALO project. But of course, today we will then go more in detail into what we have done. If you start from the European Health Data Space, this is a one-pager for what it actually contains. It is a regulation. It is a directly binding for the member states, so it's not a directive that needs to be transposed into national legislation. There are three main things from my side that everybody should know about the European Health Data Space. The chapter 2 is for the primary use. So when I'm being treated as a patient and my data is being used, the European Health Data Space provides key assets for making the care better for all of the European citizens wherever we are in EU. So the chapter 2 states that the member states need to provide their citizens their health data seamlessly and near real time without cost. So they need to provide an access to your individual health data. But it also states that when you travel from country to another, your health data need to travel with you. So if you enter into, let's say, accident somewhere on the road and you need to be treated in hospital, the doctors can get your data, your e-prescription data, your patient summaries, your lab results, medical imaging, hospital discharge letters, sent from your home country to the country of care. Also, many of you are here today from another country. If you forget your purse somewhere or you forget your medication back home, in the future in EU, you can go to any pharmacy here in Finland and get your prescription medication from any pharmacy using the prescription that has been given to you back home. So the EHDS will allow that. Another important part of the European Health Data Space is the chapter 3. It is the first time in the EU that the internal market regulates the EHR systems, so the electrical health record systems. They will have interoperability requirements and logging requirements. So you cannot place an EHR system in the European markets if you don't comply with the mandatory requirements from this regulation. The chapter 4, the secondary use, is what we are talking here today. Unlike many people who hear about the European Health Data Space for the first time, they might think that it's an IT system to store data, it's a centralized database or something like that. Actually, the European Health Data Space does not regulate the interoperability of the secondary use health data. It doesn't create a system where the data will be pooled or something like that. The main thing about the secondary use is that it harmonizes the process of how we get access to the data, how we find the data, how we can apply for the data, and how we use the data for research purposes. So it's more about harmonizing the process rather than harmonizing the data itself. I think that would be the key part of the regulation. I think for the chapter 4 still, for the secondary use, one key aspect for you to understand some key roles of the secondary use. So data user, whoever uses the data for research purposes, a health data access body, and organizations who grant access to the data, and the data holder, the organizations which has the data that the data user wants to use. So three important actors to understand their roles. This is the most simplified version of the harmonized process in the European health data space for secondary use purposes. First of all, the data need to be discovered. So each country will need to have metadata about the data in each data holder. The metadata will be published in a national catalog so that the researcher can find the data. This is the data discovery phase. Once the researcher has discovered the data, they can submit a data permit application for the health data access body, which is sort of the intermediary between the data user and the data holder. This is the data access phase. There will be a harmonized application form throughout Europe. So any researcher, no matter which country you go, you will have a similar application to fill. Once you are granted the permit, you enter the data preparation phase, where the data will be collected from the data holder to the health data access body, pseudonymized, and placed in a secure processing environment. A key topic of the regulation, the processing always taking place in a secure environment where it can be controlled. This is the use of data phase. So the data user uses the data in a secure processing environment. Once the study is finalized, the data user can publish the results, but they will not get the data out of the secure processing environment. So the data never leaves the secure processing environment. And once the study is done, the data will be removed from the secure processing environment, and it only resides at the place of origin, the data holder. This is the path that each European country will need to implement. But of course, there are a lot of details on how to make this happen. And that is, of course, why we also have the VALO project. But we also have another important project that the Finnish Innovation Fund is coordinating. It's called EHDS. And here you see the whole roadmap of the European health data space from the launch of the proposal in 2022, entering into force March this year, and when it becomes applicable in 2 years' time, and then at 4 years' time in 2029, when all the member states need to be ready with these health data access bodies, with the metadata catalogs and all the details of the regulation. Below the horizontal timeline, you see the EHDS project and VALO project, which are preparing for the European health data space. EHDS 2 in the European scale, and then VALO project in the Nordics. Green above there, it's an important factor that we don't that much probably speak today, but that you should be aware of. Any of the preparing projects that you might hear of, whether they are the ones on the slides or something else, they are making grounds for then the final decisions on the specifications that will be decided on the committee-led process between the European Commission and the member states, and that started June this year. A few words about the EHDS 2 project. It will provide guidelines and technical specifications for data users, data holders, and health data access bodies. So it's all the preparing work that we need to do to make this harmonization happen. We want to avoid the situation that GDPR brought. It was a good regulation, but then when it was implemented in different countries, the countries went on their own ways on the implementation. So in EHDS 2, we provide specifications for these guidelines, for metadata, for secure processing environments, for fee structures, for possible penalties on the data use, on many different aspects. And each country will then have good guidelines to follow to implement the regulation harmoniously in the European Union. We just published last month in EHDS 2 11 documents for public consultation. So you are here as stakeholders. If you have any comments regarding those works that we have published, please feel free to go. Use either the QR code on the screen or go to tehdas.eu and give comments. We really appreciate, and because it's a common effort also to make the guidelines as good as they could be so that they support all of you, but of course all of us who needs to implement the regulation. So that was the European Health Data Space, and of course happy to talk to any of you here on site after during the breaks or during the lunch regarding the implementation on European scale. But now we enter to the topic of today, so the Nordic implementation. When the European Health Data Space was then entered into force, or even when it was published, the Nordic Council of Ministers thought that they want to make the most of this common regulation. And we felt the same in the Finnish Innovation Fund in the Ministry of Health in Finland. When we have this new regulation, how the Nordic countries can benefit from it the most. I think a lot of the Nordic collaboration has been hindered before with the lack of common regulations. So there has been will to collaborate, but we haven't had the tools for it. Now we have the common regulations, so how do we really benefit from it to the maximum? That doesn't prevent us working from countries from outside the Nordics, of course, but we have some key aspects here why the Nordic collaboration is very fruitful. And the Nordic model, a document that we will publish next month, will give you all the details from us, how we think that collaboration will take place. And that will be also presented for you today. But we want to strengthen the Nordic collaboration. We want to prepare for the health data space regulation, and show also concrete results on the collaboration already throughout the VALO 1 and 2 projects. Okay, here's a bit boring slide for you, but I wanted to give you the timeline and what we have been doing and how also during my presentation. So we started on last year, so it hasn't been going that long. It's quite a short project with real concrete results. We started on February 2024 with the planning phase, and during the planning phase, we divided the project into 3 sub-projects that we called work streams. First one is led by Iceland, and there we are thinking about the Nordic model. So how do we benefit from the EHDS, and how do we benefit from the secondaries of health data in the Nordics? We defined a common value proposition. We defined the strength of each country and how we are sort of bigger together than individual countries and so on. And then we propose a common way of working. The workstream 2 is where we get together. So this is mainly for authorities in all the Nordic countries. So we meet every quarter. Last meeting was yesterday here, face to face, and we really got together within the Nordic countries to discuss the implementation and all the details regarding that. This work is led by Sweden. Michelle Silverstreet is here today, second row here. If you want to talk about the second work stream and understand it in more detail, then happy to talk to any of you during the breaks as well. And the third work stream is led by Finnish Innovation Fund. We do the concrete piloting on the health data. So a few slides regarding that also later. We had the first interim result in May this year in Vitalis conference in Göteborg, and now we have the final event today here. So this is actually the last week of VALO 1, and next week we'll kick off the VALO 2 project. So regarding the harmonized implementation, the work that is led by Swedish e-health agency and Michelle, we have come together 5 times so far, and each time all the member states, all the Nordic countries come together to discuss the EHDS implementation. Now this is a closed-door event because we wanted it to be sort of a safe place to discuss also the member state difficulties that they face, and that's why it's not open for stakeholders as the event today. But it has been very fruitful, and we've been able to share our maturity, our progress, and a lot of details regarding the implementation. We also, within the workstream 2, we discussed the national progress, and here's just the overall division of aspects that we discuss. So it might be national strategies, it might be organizational readiness. So have the member states deciding the health data access body yet? Do they have the national metadata catalog set up? That kind of thing. So we review our maturity each quarter, and then we see the progress of each country. We assess the technical readiness. Do we have the secure processing environment yet? Where we are with those features and so on. And it's really fruitful discussions. We go into breakout sessions where we divide it between the health data access body setup function. We discuss the metadata, and then we have a legal group where lawyers discuss article by article how they interpret things and how could we have a harmonized implementation or interpretations in the Nordics. So I will not go in detail with the national or the Nordic model, because the next session we'll discuss that. But a few words about the concrete piloting that we are doing. The first pilot was launched last year, around a year ago. We had a large public call for tender with a tendering of 500,000 euros for the first year pilot. And we asked tenderers to submit proposal on any given health research topic. So we didn't decide on which research we wanted it to conduct. The requirement was that we wanted it to use the OMOP common data model from at least 3 European countries to do federated analysis. And today we will hear about the results of that project. The federated analysis is a very promising area, but I don't want to oversell the idea. There are some difficulties with implementation. So here we had quite a good resources. We had probably one of the best OMOP team from IQVIA providing the support, and we had very advanced university hospitals from Oslo, Copenhagen, and Helsinki in the process. But still, it wasn't that clear that do we get the results at the end. But finally, we did. But it was a journey. So anyone of trying to sell the federated analysis as a silver bullet, it doesn't work. So there's a strict good use cases for using it, but it doesn't work for everything. And you really need to understand it in quite detail before you enter into the topic. But today we will hear a lot more about that, and I'm very happy that we did this pilot. VALO 2 project starting next week. A few words regarding that before I stop, and I'll let you hear more details about the results. So we will have a continuation until the September, October next year. We will continue the work we will refine the Nordic model that you will hear today, and we will refine it based on also on your feedback. So we want to hear from you during the next year of what you think about the Nordic model, so we could make it better. Also, we will continue the good work that we've done in the competence forums. So next one will be with the Radical Health Festival here in Helsinki, and then 2 other competence forums next year before we post the VALO 2 project. So we continue supporting the member states in the Nordics on the EHDS implementation. And we will conduct a second pilot. The second pilot was launched this last month on September. We had another open call for pilots. And this time, we didn't want to do the same federated analysis pilot. We wanted it to go as close as possible to the EHDS use case of using secure processing environments. So the requirement for the pilot was that you need to use data from at least 3 countries, and you need to have it in a secure processing environment so that the researcher can take direct access, remote access to the secure processing environment and use the data. And it's a bit less than what we had for the first pilot. It's 250,000 euros. And we just awarded the project last week, was it? To IQVIA. So they won the second pilot, and we get to continue on this great work. Of course, a bit different style, but still I'm very happy and looking forward for that. So hopefully many of you will come to the VALO 2 final event next September to hear the results of then this another pilot. I think that's everything from my side. I hope you enjoyed the day. And as said, I will be here for the whole day to discuss any topics that you want to discuss with. And with that, I hand over back to you, Antti and Mikael.
Thank you, Markus, for setting the scene both on EHDS and the Nordic collaboration and explaining a few words about the pilot. And now we learn more about what was done in the pilot. So Oslo, Helland, and James Brash from Oslo University Hospital and IQVIA, please come on stage and tell us all about it. And the audience, please help me welcome them.
Thank you. Okay. So thank you for the opportunity to come here and talk about our findings. I'm very happy to do so, and it has been very fruitful, and we have learned a lot. So let me see if I understand how this works. So that was not the wrong. No. Okay. Thank you. So these are the points that we want to talk about. It's aims and objectives from the pilot study, the Nordic Pilot Study Consortium protocol overview, then the final non-small cell lung cancer pilot study results, and some survey results and recommendations for future work. So in this study, as was said earlier, the aim is to explore the opportunities to increase the Nordic health data collaboration, and that has been very inspiring, I would say. In the Nordic region, we have similar healthcare systems, and sharing and collaborating in the data used is important, and we will learn a lot from that. So we have had this pilot study with the OMOP CDM model, and we will talk about the learnings as well. So as was said earlier, data from Oslo University Hospital, Helsinki University Hospital, and Copenhagen University Hospital has participated with data, and Karolinska Institute and Iceland Landshospitalet has been observers. So in this study, we wanted to describe the baseline characteristics of a population of metastatic non-small cell lung cancer patients receiving first-line immunotherapy across these countries. And we wanted to analyze longitudinal treatment patterns, including sequence, duration, and intensity of therapies. Also, we wanted to look if we could do some overall survival analysis stratified by age and country. Will the elderly patients above 75 years have the same benefit of the treatment as the youngest one? Things like that is clinically important, and we would be interested in the results. We also wanted to assess healthcare resource utilizations and costs, and that we have not completed due to lack of data. We had some exploratory objectives to look into the specifics of immunotherapy or immune checkpoint inhibitors and chemotherapy according to the guidelines, and to do some subgroup analysis regarding age. So this is a retrospective observational cohort study. The period we wanted to data from was from January 1st, 2018 and through December 23. And we had patients who were diagnosed with metastatic non-small cell lung cancer from until June 23, so that we had at least 6 months of follow-up for the patients. And we used, as was said earlier, OMOP CDM model. So regarding findings, the demographics were that the median age was quite similar across the different cohorts. The elderly range was quite, there was some differences in the age population, but quite similar. And the sex distributions showed some differences, seeming like in Norway, we had fewer women than in the other, especially in Denmark. And we are still wanting to look into those kind of data to understand more about that, as the registry data seem different than what we have found here. Yeah. So these are tables showing the same, actually. As you see, a median age 68 years. You also see that the Norwegian population seem to be quite a lot smaller than the other populations, and we want to look into why that is the case, why we lose quite a lot of patients in the algorithms. However, we see that the age distribution is quite similar, and as I said, the sex part shows some differences, and we have to look into that as well. Regarding the comorbidity, we have data both from diagnosis in our electronic health records, and we have data from what kind of drugs they use. So when using the algorithm for based on drug the patients have, we see that quite a lot of the patients with non-small cell lung cancer also have a cardiovascular disease, which we have to sort of understand more about before we draw any conclusions. Of course, both cardiovascular disease and non-small cell lung cancer have the same kind of risk factors. Smoking increases the risk, etc. But still, it's a quite high percentage. But we show that the algorithm actually can give us some results, and we just have to understand more about the results. Regarding the treatment patterns, we see that first-line immunotherapy is commonly used in all these countries. Pembrolizumab, either alone or in combination, is the most commonly used treatment. And we see that it is used both for patients below 75 years and above 75 years. We also see that less than half of the patients receive a second-line treatment, meaning they deteriorate quite quickly maybe or progress quickly. And that is actually quite in line with what we know from beforehand in this population. Regarding a duration of treatment, we see obvious differences. This is the number of days on treatment. In first line, we see that in Finland, they are treated in median 50 plus days, whereas in Denmark, it's quite a lot of higher number of days treated. And that might, of course, reflect treatment guidelines or algorithms guiding the treatment decisions in the different countries. We also see here that in second-line treatment, which obviously reflects the most fit patients, the healthiest patients, these patients are treated for a longer time in Finland. Yeah. Okay.
Okay, thank you. So thank you, Åslaug. First of all, thank you for the opportunity to work on this project. It's really been an exciting one to be involved in, and our team has very much enjoyed contributing to it. So following from Åslaug's description of the results, I'm going to talk about some of the lessons learned on the course of the VALO pilot. Towards the end of the project, we actually surveyed the three participating hospitals, as well as our IQVIA delivery team, for some of their feedback on the lessons learned. And we asked them around several categories, as you can see on the screen. So data governance questions around contracting processes, ethical committee requirements, and data permits, to data lifecycle. So where are the hospitals sourcing this data from within their networks? What is the coding systems at source? And what's the linkage potential between that data as well? We talked about the data processing. So actually in the study, what variables were we able to capture, and any implementation challenges in capturing those variables. And then issues around the study process itself. So around the ETL specification, any QA/QC processage, and problems with the package execution. And finally, we asked for feedback on infrastructure needs, capacity assessments, and also just general directive and recommendations in order to build up this OMOP Nordic network. we got a lot of feedback. And so we're trying to summarize a few points on here that hopefully I can cover some of the main items that I think are worth taking forward. Excuse me. So on this first point on capability maturation and organizational readiness, we really feel that technical voices need to be part of the data governance process at all points. And that's the way that we can ensure that the data that we need for these type of studies is captured comprehensively at the level that we need it, and then OMOPed accordingly into the way that we need it for the study. Excuse me, I've not done very well on the flight over. And the second part of this, the organizational readiness, is really about this being a team effort. It can sometimes feel as though you're sending an analytical package out, someone executes it on their side, and they send you back the results. But that is really not the case. It's really a multidisciplinary effort at all of the sites. It requires data scientists, ETL analysts, people that know the data inside out, and clinicians as well, in order to make this all work. And they're all busy people. So we also need a PM-like figure to coordinate the activities of the group. And this was one of the feedbacks that we got from the sites. So we need someone that can interact with the study delivery team. In this case, it was IQVIA, to also coordinate the activities and the responses from the people at the hospital site as well. The next 2 points I'm going to summarize together. And really, this is about the idea that we can run feasibilities and what I would call study viability, so data profiling, at the early stages of this process. We don't want to lock in a protocol with specifications on exactly how a study is going to be run until we really understand whether we have these patients and the variables that we require at the sites. So we need to think as a network, how can we do this? How can we profile data before the point that the protocol has been fully approved and accepted by the boards? Or do we take the alternative route, which we develop protocols that are vague enough that we have flexibility to then finalize once we've been able to profile what these patients look like, what variables do we capture, and in what depth? The data processes and technical infrastructure. So as it was mentioned, this study was run on a network of OMOP databases. And OMOP is a fantastic tool for harmonizing your healthcare data for interoperability on these types of studies. It gets you most of the way for harmonization, but there is an area where there's still a bit of flexibility. And I'll give an example of this in this study, for instance, histology records. There's several areas within the OMOP database where they can land, and that's an other layer of complexity that you have to then consider in your study. It takes longer when you're profiling the data. For the data scientist, you then have to code a more expansive code in order to capture these variables. So as well as implementing OMOP, which is going to harmonize the network to a substantial degree, there's a level of integration between the network that you can do in order to make sure that some of these more difficult variables, particularly measurements and biomarkers, that's a really tough area, that they're standardized across your network so that then as the OMOP Nordics, you run a lot more efficiently as well. Then there's the study execution and quality assurance stage. Clinical review is essential at every stage of this process. We don't want to be at the point where the clinicians are seeing the results at the report stage. In fact, we need them as early as the ETL stage. We need clinician insight to guide some of these ETL mappings, particularly those that have to be custom done at a specific site. We need them to confirm our patient selection at the early stage of the project when we're doing our feasibility assessment. And also we need them to review at the first round results. I think Åslaug was being very kind in her description of the results. There's a lot of questionable things that we found, and if we had more time in this project, I think we would dig deeper into understand why do we have such attrition at one site? What were we missing in the study here? Why do we have 99% of patients on cardiovascular drugs? Is that real or not? And we need that clinician view at every single stage of this study. And the final thing I would say on these points here is the methodological advancement. In the VALO protocol, we describe the study where we select patients, we do a descriptive study, all the way to an inferential Cox regression model to see which factors are influencing survival for these patients on ICI. That's a lot in a relatively short time frame. And what we would strongly advise in any sort of network study is that you phase this out. First, focus deeply on capturing the patients that you think you need for your study. Then go into the descriptive analysis style study. And at that point, you have a standing cohort who you understand very well on your network, which you can then bring forward to the more advanced inferential statistics that are going to give us the clinical grade insights that we need from these real world evidence networks. So this slide, it largely covers the same points, but there's two things I'll point out on this one as well. The data permit timelines were quite surprising to us. It was 1 to 4 weeks with the process at the hospital level. This was a lot quicker than we were expecting when we plotted the timelines for this study, which was a great benefit. And I'm going to talk slightly on the technical side, if you allow me, as someone on the data scientist background. There were some technical challenges. OMOP and the tools surrounding OMOP from the Odyssey and the Darwin communities are designed to run against databases in different formats, Postgres, Snowflake, Databricks, etc. But we still run into a lot of problems with this. So it's very important that you have a data scientist on the other side at the site who can work with you to overcome these impediments. And I'm going to flag as well for anyone in the audience who's going to be leading any of these type of studies. Measurements is still a very difficult area of network studies, if not the most difficult. There's a lot of variance in how measurements are captured, both in the code, in the units, in the thresholds, categorical, numerical. We came across this in this study with PDL1, which was recorded in different ranges at different sites, which makes it very hard to then compare. We're not comparing in this study, but it makes it very hard to present those results within the same table if we're talking about different ranges. We don't have very good tools in the network for profiling measurements, and we don't have very good tools for analyzing them yet. So there's a lot of space to be done, not only in the OMOP Nordics here, but within the wider Odyssey Darwin community. And I know that there are some tools coming up, so watch this space, but it remains a very big pain point. So these are the immediate learnings from, well, a flavor of the immediate learnings from the pilot project. I think a lot of the feedback we've got is that although there are questions over some of the results and we don't consider them as clinical grade yet that we could actually take this and make decisions from this. We have more investigation to do is why we have some of these results. But there was a lot of lessons learned in the immediate short term. But in the longer term recommendations, we've broken down into sort of 3 main areas that we think should be considered. So tier 3 data development, funding diversity, and actually there's a discordance here, but advanced analytics platform. So tier 3 data development is again about building that pipeline where you've got comprehensive, high quality data coming into your OMOP instances. And this requires clinician buy-in. So we really have to get the clinicians, we have to communicate the benefit of RWE to the clinicians for their patients, because otherwise why are they going to get involved in these processes for us? Modifications to EHR, if possible, so that we're capturing more data in a structured format. Some of the feedback we had was that some of the variables are captured in an unstructured manner, which made it much more difficult to get it into the OMOP instance. Is there room that we can work on this collectively? And ensuring that we're building in quality monitoring and feedback loops into our pipeline. This is really on the technical folks, making sure that we have sufficient checks as we're collecting data, putting it into our instances, mapping it into OMOP. There are tools within the OMOP community, but it's also very good to have your own internal tools as well to make sure that these processes are going smoothly. The network funding model, this is slightly outside of my area, but really the sort of points that we considered here was continuation of core infrastructure from government or foundation services, also the exploration of a fee-for-service model for commercial studies, leveraging the network capabilities, academic grant funding for academic studies, development of technical innovation, and so forth. And then finally, the advanced analytical platform. It's very important that any of the participating sites has an environment that's compliant with security regulations and patient privacy regulations that they can run these studies on, has sufficient computing that it can run the more advanced analytics, and also there's a decision to be made from our experience in the study. Some sites have to set up an environment per study, and that can be a lengthy process. How can we bring that process back? How can we make that a quicker process? Or can we move to the world where we have a standing environment ready to take part in federated analysis as well? And that very last word I said, federated analysis, is a confusing word because in our community, it means 2 things. It means a federated network like we've taken part in here, where we will give a package to each site, they will run it on their site and share the results back. But it also means federated learning, which is probably the next step along from this process. So once you have your environment, do you want to start looking at federated learning technology where you can run these type of studies without getting too technical collectively So it effectively treats the sites as though they're one without the data ever leaving the sites. Just some food for thought. So just to finalize on those key points again, so making OMOP part of the regular operations, ensuring that we have comprehensive data capture at a level that we're happy with because of our quality checks and a sufficient ETL mapping that into an OMOP instance. The second point, really, I think one of the biggest points, this is a cross-functional team effort at each site. It's not a data scientist on a database. We need everybody involved, and we need a PM-like figure to coordinate that with the delivery team as well. And then at the bottom, the idea that we phase these studies. Let's be confident in our cohort selection and our description of our cohort and have that as a standing cohort on the network. And then we can move forward to some of these more advanced, interesting analytics that are really going to give us the clinical grade RW that we all want to get from these type of networks. So again, thank you for the opportunity to be involved in this project. I really mean that. It's been really exciting. I've been involved in a lot of OMOP network studies, and I think this has been one of the most successful. And it's really down to the teams at the different hospital sites. Fantastic setup of the OMOP instances. One of the only network studies I've not had issues with OMOP instances. It's been brilliant. So thank you very much for letting us be involved.
Thank you so much, James and Åslaug. I think you gathered the same as me. This was really a study about a study. So not just the medical results that we got, but the aim of the study was also to study how these kind of studies can be done, and are we there yet? Are we already in a position when we can just send an analysis script to our site and then get meaningful results back? Perhaps we can send a script and get some results back, but it seems obvious that we are not totally there yet. There's something to be done. And to share even more insights to OMOP and the future of that, I invite Gustav Klinstedt to host the next panel, and Severin Kohler, Talita Duarte Sayes, and Christian Höberg to discuss and share their insights. Please welcome them on stage.
Thank you so much, Mikael, and thank you, Åslaug and James, also for the previous presentation, which I think very well sets up our discussion here. So I'm gonna introduce the panelists one by one, and we're gonna have a brief chat with each of them to begin with. I'm gonna start at the far end. This is Talita Duarte Sayes, Assistant Professor of Medical Informatics at the Erasmus Medical Center. And you have perhaps some similar experiences to what James and Åslaug were talking about, in that you, at the Erasmus Medical Center, especially the Darwin EU project, you run these federated studies. Could you tell a bit about how you got involved with OMOP and what you are doing at Erasmus Medical Center with Darwin EU?
Sure. Hi. Good morning, everyone. Can you hear me well? Yeah. So it's a real pleasure to be here today. Thank you to the organizers for the invitation. I'm very happy to be here. It's a great opportunity, and I've been meeting a lot of people, and it's very exciting to see all the work that you're doing here in the Nordic countries. So yeah, I'm Talita Duarte Sayes. I'm an assistant professor at Erasmus MC in Rotterdam, in the Netherlands, and I'm also leading a group of real-world epidemiology at IDIAP Jordigo, which is a primary care research institute located in Barcelona, in Spain. And I started working with real-world data 10 years ago, in 2015, and that was when I got actually started with OMOP. And my first task was to map the CDAP database, which is a large primary care database in Catalonia, in Spain, to OMOP. So that's where I started my journey, and then with time, then I joined the team at Erasmus, and I went from working with 1 or 2 and 3 databases like IPSI, CPRD, CDAP, so like primary care databases, to all of a sudden now working in Darwin, where we are working with 30 data partners, more than 35 or 40 databases actually, because we have OMOP, for example, where you have, it's one data partner, but with access to 4 different databases. And Darwin, I don't know if people have in the room have heard about it, but it's a big project funded by the EMA. And at Erasmus Medical Center, we are the coordinating center of Darwin. And it has the aim to generate reliable evidence to better inform decision-making in the regulatory field through real-world data mapped to the OMOP common data model. So it started in 2022, where we did 4 studies, and we went from 4 to 18, 38, and now we are running more than 60 studies this year already, with the goal to get to the 100 studies. So Darwin, what kind of studies we're doing? We are doing very simple studies looking into the time trends of incidence and prevalence of a disease, drug utilization studies, and then to more complex studies where we're looking into comparative effectiveness of vaccines, of comparative safety of medicines. So that's a little bit what we're doing in Darwin. It started with 10 data partners in the first year, and every year we've been onboarding 10 more data partners, and we have now 30 getting to 40 this year. And the project will end next year, and hopefully it will get extended. Let's see. But it's been a great journey. I think James summarized very well the lessons learned with one study. You can imagine the insights that you get when you're running 100 studies, right? So I don't know if can I share a little bit of like the lessons learned?
And it would also be great if you sort of really take it down. What would a typical study be if you talk about, for example, a simple study? Like really, what would be a successful study, and what would you do in that?
Yeah, so usually we get a request from the EMA, and this request can be coming directly from the EMA or from the different committees around. And then we check for feasibility. And that's, as James already mentioned, it's a crucial step because you need to make sure that we'll be able to deliver. So sometimes there are complicated questions and we need to see, do we have the data to answer those questions or not? And then once we say yes, we can do the study. We start with the study, and usually we are including around 5 data partners per study, but we have studies now with 10. And we have more very complex studies where we are including all data partners in the network. And you can imagine how it is to work with so many data partners. And then the questions, as I mentioned, like incidence prevalence, drug utilization over time, safety. I think one of the things that I would like to highlight in Darwin is that we are able now, thanks to OMOP and the standardized analytics, to perform studies much faster than we used to before. So we're going to an off-the-shelf study, so a study where we're looking into incidence prevalence. It could be 3 months to conduct it. I think before it used to be 1.5 years or 2 years to do a study like that. And now we're able to run the studies with 10 data partners at once, and answer those questions pretty fast. Yeah, I don't know if I'm answering.
Yeah, that's very nice. Actually, to set up the next panelist, I'm going to ask a little bit about you working with Nordic partners, and we're getting the Nordic dimension. So for the audience, I'll just, and especially for the Finnish audience, I'll just mention that FinOMOP is part of the Darwin EU network, and we have a consortium consisting of the Finnish Institute for Health and Welfare, along with at the moment 3 of the university hospitals. So HUS, Varha, and Pirha are in the Darwin network currently. But please, Talita, could you talk a little bit about, because you have experience probably with most of the Nordic OMOP data holders, I would say, and sort of do you see any commonalities between them, and do you see any differences perhaps, without getting too specific on the differences between the Nordic countries as well?
I think, just what we've seen in the previous talks about collaboration and just building this network is quite impressive. Then I think to me, like working with all these databases already mapped to OMOP. Again, it's having all this different. So we have now in Darwin, we have Denmark, Sweden, Finland, Estonian Biobank, and I feel like I'm not Norway, did I mention? So Norway, Sweden, Denmark, Finland, and Estonian Biobank. Yesterday, I found out about a little bit. I was chatting with a colleague about the Icelandic data, and I found out that it's not mapped yet. So hopefully we'll get there. And my experience has been very, very positive. We're using, as you know, the Nordic databases a lot in Darwin. Yeah. We actually did a study on non-small cell lung cancer in year 2, where we only had the Dutch cancer registry data and a couple of hospital databases. And I wish we already had all the Nordic countries onboarded, because I mean we can see the potential for research in that field. It's been really great working with these databases. I think looking into all the possibilities with the linkages that you have, the national coverage, and then the speed. Also, we were talking a little bit about IRB approvals. You know, this, if you have to do a study in 3 months, if you're spending 2 months just waiting for approval, it's not very exciting. You're like there just waiting, you know. And I think with the Nordic countries, we're having a good experience. As James already mentioned, they were surprised that they managed to have approval in like 4 weeks. So that's also a positive thing about working with the Nordic data. Yeah.
All right. Thank you so much. I think we're going to move on to Sweden next. And this is Christian Högberg, health data entrepreneur, affiliated with Edens Health, as well as Passion to Improve AB. And you have been thinking and working a lot on getting OMOP established in Sweden and getting the Swedish node up and running, so to speak. But you could start by maybe telling why you got into OMOP in the first place.
Yes. Well, I'm actually, I'm a newcomer to this space, I would say, in general. I don't have a background in life science. I don't have a background in healthcare. But I have been driving change and transformation in other ecosystems with a strong focus on converting data into insight, driving change and improvement. And I know that the effectiveness of using data to drive change and improvement is so much more effective than using qualitative data, even though qualitative data can be also useful, of course, but the level of effectiveness of using data to drive change and improvement is outstanding when you have qualitative data and you merge it with the people in the ecosystem. That's when the magic can happen. So I detected OMOP about 1.5 years ago. I saw the movement in the world, and I also studied Sweden, and I saw that Sweden has a lot of good assets, but for some reason we haven't adopted OMOP to a large extent. So here you have a change leader where you have a problem in a country like Sweden, you have a lot of assets in a country like Sweden, and then outside of Sweden, you have a lot of solutions that has been tested and evolved continuously. It's like, we need to merge these things together. So I decided to jump in because I do feel that if we can succeed with this, both Sweden and the world can contribute or can create a lot of value out of it. And then I can rest and have a pension, done something great for the world. So yeah, I took the initiative. My mentor said that if you don't see the leadership, take it. So initially, I've temporarily taken that leadership and tried to mobilize attention in Sweden to the fact that OMOP exists. All these methodologies and tools exist, and all these expertise and all the activities going around the world, it's there. It's up for grabs, and Sweden usually wants to lead. But in this case, we haven't led. But we have an opportunity now to learn from all that's happening and see how can we do it in a smart way. I've seen in many countries, I've heard from people that worked with this, that OMOP has been kind of growing organically in many countries. People taking initiative, I want to harmonize our data, and it grows organically, which is a way. I think Sweden can learn from that, and we can both have a top-down kind of approach. How do we do it smartly? Because growing it organically also creates effects that you can avoid. So being here, talking to experts like yourselves, learning from other countries, engaging these expertise, and then if you want to transform an ecosystem like Sweden, you need to build on that ecosystem. the leaders that are there, the expertise that is there, the data that is there, the ongoing, different initiatives that there. All of that, all the solutions are actually in that ecosystem, and you need to just dive into there and then start to connect the dots and bring in the expertise and so on. So it's a transformational journey that we're on. But I see a lot of opportunities, so it's quite thrilling. A year ago we had a few early adopters in Sweden, and now the movement is moving. So I'm very optimistic.
That's great. Would you perhaps want to take it a little more concrete even and just mention what's going on currently for anyone interested in perhaps being there with you in Sweden?
Yes. So well, we on one side we're mobilizing to create awareness. So more people need to know what OMOP is about and how can it benefit me. So the different user groups in our ecosystem needs to pay attention to it and start to invest time to learn about it. So we're doing a lot of communication in that. We have an event next week where we had one a year ago. We had about 100 people. Now we have close to 200 people signing up for this event. The authorities are starting to get more and more interested. Progress is not always the speed that you would like, but yeah, and then there's a lot of more organizations now interested in actually harmonize their data sources. So I have a pipeline of players who actually wants to do it, and now it's the question of getting funding to do it, getting attention, and mobilizing. Be pragmatic about it and start to apply it. And so yeah, we have a pipeline of different entities that wants to start to harmonize their data. Of course, we're looking for funding always. So now there's discussion of additional funding to fuel this effort. So there's a number of things happening.
Thank you, Christian. I think I'm going to move on at this point. We're going to perhaps widen the discussion a little bit. This is Severin Kohler, interoperability researcher from University Hospital of Heidelberg. So we're taking the discussion a bit also wider than OMOP. So we're talking a little bit perhaps about Open EHR and FHIR as well. So please introduce yourself and tell us a bit about your background in this model.
Thank you. First of all, again, thanks for being here and getting invited to this marvelous place in Helsinki. So my name is Severin Kohler. As you already said, I work for the University Hospital of Heidelberg. Also, I work for the Charité of Berlin. So you get kind of pushed where the project money is basically, it's research. So I spent the last 8-9 years looking at electronic health records from a secondary use perspective and really try to understand how do we live up to the expectations of research now, but also in the future. And in that work, I spent a lot of time taking a look at these standards and trying to understand them. And as part of the HIMED consortia, which was a research consortia consisting out of the biggest university hospitals in Germany, where we built a similar federated infrastructure, which different use cases on cardiology, infection control, and oncology. But we didn't took for that OMOP. We actually used OpenAir for that. And I'm going to take a small dive into that. Why? Some of my work has been especially trying to bring standards together. I'm leading 2 work groups between HL7 International and OpenAir to bridge the gaps between those standards. And I'm also kind of leading the work group in regards of OMOP and OpenAir. So now I talked a lot about OpenAir and why we did it. So when I looked at the standards, and we have a research environment at Charité too, our work group Charité is huge. So I'm not speaking for every group at Charité. We have over 3,500 beds at the hospital and 15,000 employees. So be aware that what my work group is doing is not what all of Charité is doing. At least for us, we decided to take as our kind of core system OpenAir and then move into other standards like FHIR and OMOP, depending on the projects we have to satisfy. Yeah. So in general, I think the good part about the OMOP is really having this vision of not having to sharing your data Because people always come to me and say, we are going to share the data. And at the time, do we really need to share data? Can we not actually share the calculations on the data? Because if we use the same database in regards of OMOP, we do not have to actually share data. We are sharing outcomes. And I think this is where we have to strive in the light of privacy for patients and so on. Exactly. So what we kind of found out when we looked at Charité and tried to establish like an architecture, that when we look at future needs, actually OMOP didn't scale very well. It's also because consistency of the database, everyone that worked with OMOP, just go out in Europe and ask what the visit is and the visit detail, and you will find different flavors or even the episode of care and so on. So internally, anyways, we decided for OpenAir because it has these international models, because we wanted to be able to represent all of the primary use data, because I think it's actually wrong trying to invent a standard for secondary use. I think you need to go from primary use because this is where the data resides. If you do not do that, you will end up recreating an electronic health record. So I think it's actually kind of short-minded to say, we just create this new standard, but it's not doing an EHR. Well, for research, you will need an EHR, and you will need all the contextual information. You will need detailed information, and you will need to be able to persist that. Research is growing more complex every day. So at least for us at Charité, we drive a hybrid way. We import into OpenAir to be able to have all this semantically rich data, but we also build an open source and freely accessible transformation tool to OMOP. So we just satisfy both. Very simple. If we need OMOP, we have the data accessible. If we need more complex research and hypotheses, which can be quite mad if you talk to researchers, we are able to satisfy both. So and that's been most of my work, trying to understand, okay, what do researchers actually want? And just getting along and trying to understand. Still ongoing journey though.
Yeah, thank you, Severin. So these different models, OpenAir, FHIR, OMOP, they're sometimes seen as sort of competing, and certainly for some in the audience as well, they might be asking themselves where to put the money, but in reality, of course, they are complementing each other, and there's use cases for each of them. So could you perhaps just again in as simple as terms as possible, break it down. What would you see are the use cases for OMOP? What would you see are the use cases for OpenAir? And the limitations of each of them as well. And I think I'll have Talita in on the same question later as well.
So in general, OMOP is very easy to use. It's very straightforward. It's just a row of tables, so it's very easy to understand. And I think you can get results very fast. And I think via that, it's easy to grow a community. You have a marvelous amount of studies. I would be proud of that amount of studies. So you see, it's very easy to grow a community and reach outcomes. So I think OMOP is very good at facilitating research in bigger communities like in Europe and so on. So I think this is very good. The limitations, as I said, it's not semantically very well scalable. It reaches limitations very fast, and it can be, but all of the standards can be inconsistent. It depends on. I mean, I can just speak louder. So in the end, it's just the ETLs. In the end, it boils down. But that's for all the standards. For OpenAir, I mean, OpenAir. What? It's my beard. Closer to my face. Okay. It's now better.
Yeah.
Good, let's try that one. Okay, I hope you understood so far what I said. It's fine? Okay, perfect. For OpenAir, it's much more complex to adapt. It has a much higher, so it's not an easy way to do things. OMOP is much easier in that regard. It has better tooling support for research. But what OpenAir solves is actually, in the end, it comes from primary use for the electronic health record. So you have all the data you want to have for research. So I think, as I said, they're complementary. I don't think there's like a silver bullet. And I think because the word Europe is heterogeneous, we're not, I don't know, a dictatorship where the European Union says tomorrow, oh, you all do exactly like this. It's not going to happen. And with this heterogeneity, we have to, understand, okay, there are different standards. They evolve for different purposes and try to solve different problems.
Yeah, thank you so much. So Talita, maybe you can, especially from the OMOP point of view, just again sort of list or go through the different kinds of analysis that you can run with OMOP and that you are able to do with the network that you have available.
Yeah, I don't want to repeat a little bit that, what I already mentioned before on the type of studies, but I do want to complement a little bit on what you said about OMOP being having this structure that sometimes limits you. I just want to say that I think, that OMOP is flexible and we work in a big global community. And I think there is room to change things. And it has changed over time. If you look at the first common data model to where we are now, it has changed with time. And one example is in the field of oncology. We now have an episode table. We now use ICD-03 codes as part of like the standard code. So it's changing, and it's changing because we are using it a lot. And the more we use it, we realize, oh, actually we need this, we need that. Somebody was asking me about, what do you do when you have data that is very particular from your own country? Or, for example, in CDAP, we have a socioeconomic status measurement, that it's not available anywhere else. So what do you do with that? Because you still want to use that for research, yes. So we find ways, and there are ways to include it in your CDM. For example, for the socioeconomic status, we just map it to the observation table. It's there, we know it's there, so we use it for research. So I think it is quite flexible in that way. It just takes time. It's not like tomorrow I will add new things. Another example is the pregnancy field that we are now also working quite a lot. So in the past, before having the episode table, we created in my team like this perinatal expansion table, so a separate table to have, pregnancy episodes and being able to identify pregnancy IDs linked to the children and all that. And now with the episode table, we're saying, oh, wait a minute, maybe we don't need it. So I think there's a lot of room for improvement, and we are going towards that. And I just wanted to mention that also, because I'm mentioning oncology and pregnancy, and this is because we are now starting the first two very complex studies in Darwin. One is in pregnancy and one is in oncology. So I want us to also, I've heard this criticisms towards OMOP of being like this box of this is how you have the data. But I think we are an open community and people are welcome to bring suggestions to the table. Look, I want to do pharmacogenomic studies. We have the Estonian Biobank colleagues that have done a great amount of work on how to integrate that into that kind of data into OMOP and doing that kind of studies. And I'm sorry, I feel like I'm not answering your question, but
Go ahead.
I felt like I needed to jump in and I'm not. I feel like now I'm selling OMOP, and it's just because this is what I've been working on. I don't have experience with the other common data models. So
yeah. Do you have, Christian, any takeaway from this almost a debate happening?
Well,
sorry.
And I still feel like I'm kind of not in the heat of anything of this, because I look at it from a broader change perspective. And if you want to become good at something, you need to practice a lot.
Yeah.
You need to challenge the things, and you need to cross-fertilize people and so on. So for me, this is a journey that we're all on, exploring. We need to find ways to convert data into insight and use the insight to drive change and improvement. Are these perfect tools today? No. But maybe 10 years from now, 20 years from now, will they be better? Of course they will be better. They will be, we appreciate all the work that Charity and Sabrina is doing is with open ways to now map from open air to OMOP. And we need to work on this. We need to practice and polish. My world has been a continuous improvement and learning, and that's what we need to continue to do. But if we don't pay attention to it, we won't practice.
Yeah.
So in Sweden, this is the call for Sweden. It's like we need to pay attention to this and start practicing and start connecting the leaders and building capabilities of different levels, and then we will become better and better as a collective, not just Sweden but everyone. So I don't perfectionism doesn't exist. It's like you can always cut down on anything. even if you're the best tennis player in the world, you can get better at this, like so.
Yeah, thank you. So my perhaps my own takeaway from the discussions with Severin also yesterday with OpenEHR is that it's very much adoption of OpenEHR is very much a step forward also for generating analysis data sets, whatever format they be. And of course there is a good example in Sweden as well of Karolinska building their new infrastructure on OpenEHR.
Yeah, I think, can I just add one thing? So what I see when I listen to the world, the experts, is that we're kind of in agreement. Like OpenAir, yeah, it's a lot about capturing in a smarter way, which is really important, that we become better at capturing the data. Buyers, to exchange the data, and OMOP is really to start using the data in a big context with a lot of data partners and so on. So I see this everywhere. We don't need to kind of find out more. We need to get into work.
I think the thing is, which if you want to address actually the problems of research and AI in general, you need data. And currently it's garbage in, garbage out, because the electronic health record systems are in the end billing systems that have been bent to do clinical documentation. Everybody that worked with the hospital information system knows that. And I think if no matter what we do, if we do not manage to clean up data at the point of capture where it actually arrives, we're going to run in circles.
Yeah,
I think this is the most important thing. And then it doesn't matter, right, if you go to OMOP or whatever it is.
Yeah. So to reiterate again, OpenEHR adoption is about how to get a good data capture, whereas OMOP is a format that you arrive at when you're doing your analysis, and then obviously the better your source data is, and the cleaner and the more easy it is to interpret it, the better also the data products.
For example, we run prospective studies with capturing actually form data. That's OMOP doesn't just simply support that, at least not that I know of, and we put it into OpenAir. It's entered directly in OpenAir, so there's no ETL, nothing. Doctors enter it directly in our CDR, and from there we transform it to OMOP or to FHIR depending on the project. So you see, that's just complementary then, right?
Yeah.
Maybe if I can
Talita,
add,
please.
I think you just touched on a very important point, which is the data quality. And we have also this criticism sometimes towards mapping of data, but most of the times it's related to the source itself. I think we do a lot of work on this mapping of the data. And when you do that, you actually end up knowing a lot about your data. And it's a knowledge that sometimes you don't have if you don't map, because the data is just there, right? And I think that exercise of mapping and getting to know better your own data. And then another thing we're seeing, of course, when you run this number of studies, you start finding the problems. And of course, there are problems of mapping, but a lot of times there are also problems on like how the data was recorded in the source itself. So that's why it's very important that we work as a team with the data partners and clinicians who are actually recording the data every day to understand and interpret the results that we're getting.
I want to add one thing to that because it's interesting. One thing that people tend to forget, just because you write an ETL in a standard doesn't mean you represent the same semantics. And by providing a standardized transformation from a clinically valid standard, which you have in OpenAir, which is quite broad, you also provide consistency to OMOP databases. Because you map OMOP, people interpret totally different stuff. Visits details is a good example. This is very important. Just because you adopt something and some field doesn't mean, or date times is also a very good topic, right? There's a date time of documentation, a date time of where the actual condition arrived, when it ended. So what are you reporting? So, and this is very important. Just because you write an ETL doesn't mean the output is the same. So we really, that's at least my opinion, we need to standardize the ETLs to some bits, because if we don't, there will be inconsistent CDMs, and inconsistent data means inconsistent study outcomes.
Right. I think we're gonna do one final sort of rundown where I would like you to more address the audience with your sort of key takeaways. Where would you see perhaps OMOP going or OpenEHR going, also in the context of EHDS. So what's in it for them? Who wants to start? This was a very hard question. Maybe Christian, would you be so kind?
Yeah, maybe what I do see is I think the EHDS is definitely a strong enabler. You know, it's an enabling force coming in, and more people in the ecosystem is paying attention and waking up. You know, we need to do stuff. You know, what I don't see though is that we're not taking it as far as we would need. It's a lot about, you know, what's data out there, how do we access it, how do we provide it, how do we secure it, and so on. But we're not talking sufficiently about making the use effective or the data preparation effective. So I don't see that EHDS is daring to take the steps even further on harmonizing the data sources, because I foresee, I'm not sure I'm so far from the truth, is that once you know, EHDS opens up and this possibility exists, we're going to face a lot of new challenges. In England, for example, they have seen, you know, with the secure process environments that they have, I think they have 14 to cover their country. What if you want to use data from different secure process environments? And well, we need OMOP to harmonize that data. So I think, you know, the health data access body is going to face a lot of challenges in the future, because in Sweden, yes, we have one data source that's harmonized more or less well and using, but a lot of the data sources are not harmonized, which means that people are going to want to have access to the data, and it's like, well, but the data is not in the common format or common structure or common semantics. So then you need harmonization of the data, and we are not investing any effort or time in that. So Sweden needs to look at how we're investing money and see what are the missing piece that will enable us to also make the use effective. Because in the end, if we don't get the use effective, all these investments that we're doing are actually for nothing. Yeah. Because the data is not going to be used.
I think Talita wants to have a word in here.
No, maybe just to add, because my opinion of like how I'm seeing, and I think some colleagues already mentioned, that you want to lead the way, and you are leading the way in Europe, I think, on how to do things. And I think Finland is a great example. In Darwin, we have one data partner that's FinOMOP, who has access to 4 different databases, including the hospitals, the registries. I think that's a great example to like how in the country you already collaborate and have a network that works well and create the procedures. And of course, there's room for improvement, but it's already, you are leading the way, I think, in this journey of like EHDS for sure. We do need more resources into improving that mapping in different countries. So we started working a lot with Estonian Biobank, FinOMOP, and then all of a sudden Norway, Sweden and Denmark jumped in, but there is a lot of work still needed to get that data into the status of like, okay, very mature into mapping, and we realize, that, we will map the birth registry next year, or we will map, so there are a list of things. I think you're already in a very good position in the data that we have access to, and now we just need to make sure that it is in the right place for us to work. But just building this collaboration, the VALO, it's pretty impressive. And to me, like, I think you are already leading the way and in the right path towards EHDS. Yeah, I'm very impressed.
Thank you, Talita. And Severin, do you want to?
I second what both of them said. You're smart people. I think, so I'm a skeptical person. So I think in general, unless we do not manage to fix integration, this will not turn out. We will achieve something, especially in regards of regulation, but unless we do not manage to clean up the integration, which the EHDS is currently not regulating, so I can kind of get a structured EHDS message, but I'm not actually enforced to integrate it in my system. So I can just build a viewer and I say, look, I'm supporting EHDS, but the data is not actually in the system. And this is in the end the problem. If you do not solve this, it will be running in circles to some degree. I mean, there will be steps. Obviously, EHDS is really valuable. And I think especially OMOP is going to grow more and more. There will be more and more data accessible, and the extensions will grow for pregnancy, for oncology. And I think especially for secondary use, this is super valuable. I see both of it in the end positive, but I think also we could do much more. I mean, let's reach for the stars, right? I think less is more is not doing the trick. We're talking about clinical stuff, right? Less is more in the worst case endangering patients.
Thank you, Severin. And I don't think I have to say much more at this point. So didn't we have a wonderful panel? Thank you so much, Talita, Christian, and Severin.
Thank you.
Thank you for the panel. Antti, any thoughts? What did you capture from the session so far?
I think it was really interesting morning. First, I'm glad to hear that VALO 2 is coming up right around the corner. And actually, there's one thing still left on VALO 1, which is the citizen survey on secondary use. That's going to probably like segue us into the VALO 2. We don't have any results yet, but during this year. Then I really liked about the pilot. They had the idea of not just building something for one instance, but rather establishing a continuum of things. And I think that's the direction where should we go. And then from the panel discussion, I really like the hands-on approach, and this is a living proof and demonstration that future is made. So that was something that really grasped me.
Good. My insights from OMOP, from panel. Yes, there are these data models. Use OpenAir to make sure that you capture all the data possible. Use HL7 Fire to communicate that between systems, EHRs, apps, all of that. And then use OMOP to actually study the data. And none of these data models are complete and ready yet. Rather, they keep evolving. And not just the data models, but we really need to ensure proper incentives for people actually generating the data and systems generating the data. So something to work on that.
Yeah. Next.
And don't go there yet, because I want to introduce the next act, because this was an excellent warming act from different presentations. And next we will have the first main act of the day. And it is you, dear audience. So fika pause, as we say in the Nordics. And that means coffee break. And also people online take the opportunity to stretch, go out and get something to drink, and also share your views on the chat. And now, Antti, over to you, and you can...
Thank you.
Thank you for that.
Yeah, some housekeeping. So we have restrooms on stage right, both floors, and the coffee is served right behind you upstairs.
And restrooms are there as well, up and left.
Anything else?
Yes, something. Beep.
Oh, yeah. We'll continue 11 sharp.
So yes, do discuss, do have discussions, but do remind yourselves that you don't need to finish all the discussions in this event. So it's totally okay to say, yes, let's continue this discussion afterwards and be back 11 sharp. Thank you. After coffee break, we have the session 3 on advancing the Nordic collaboration in health data. And if you still remember the introduction of Markus to the VALO project, this was the work stream 1 led by the Icelandic colleagues. And Rebecca will come present us the Nordic model, and then we'll have a panel after that discussing the pros and cons and insights to the Nordic model. Rebecca, if you're ready, come on stage. And audience, if you're ready, let's welcome Rebecca on stage.
Should I just press the middle?
That's forward.
Oh, thanks. So thank you. Hi, and thank you for being here. I want to share with you a proposal of how we can advance Nordic collaboration through a Nordic model for collaboration. The Nordic countries possess unique advantages for cooperation on the secondary use of health data. We share many strengths, such as population-based health registers, with data collected over long periods, unique personal identification numbers enabling data linkage, high levels of public trust and willingness to participate in research, and similar healthcare systems with shared values around data protection. These advantages position us well to become leaders in health data utilization, particularly with the forthcoming European health data space. Yet, through stakeholder discussions, we have identified significant challenges that prevent us from fully realizing this potential. Nordic health datasets are underutilized for research and innovation. Our stakeholders talk about frustratingly long and unpredictable timelines. One stakeholder called data access their single biggest challenge for competitive positioning. They're forced to choose between waiting for quality Nordic data or using inferior alternatives. Cross-border collaboration has become particularly difficult. As one stakeholder put it, it's very rare that we collect data in all Nordic countries and merge them together because it's just too complicated. The root cause is legal and regulatory fragmentation across our countries. This creates complex procedures, standardization issues, and institutional barriers. What's most concerning is how stakeholders have adapted by simply limiting Nordic collaboration. These challenges demand a coordinated response and have a critical opportunity ahead. In 2016, the GDPR regulation entered into force, aiming to harmonize and reduce regulatory complexity, but having the opposite effect as each country interpreted it in their own way, resulting in increased regulatory complexity for Nordic collaboration. Now, the European Health Data Space regulation entered into force earlier this year. We can use it as an opportunity to coordinate and harmonize the implementation together within the region and therefore preserve Nordic advantages while meeting European requirements, so that in the future, the Nordics can maximize the benefits of Nordic cooperation in a more efficient way. Therefore, we propose a new vision for Nordic collaboration. We propose a Nordic environment that empowers stakeholders to collaborate in advancing health data research, development, innovation, and policy making, to benefit health and well-being and economic prosperity. This vision builds on the region's distinctive strengths while addressing the opportunities created by EHDS implementation and growing global demand for responsible health data use. The proposition aims to combine strong academic institutions, effective healthcare systems, and supportive government policies. Shared values emphasizing transparency, equality, and evidence-based decision-making create natural alignment that facilitates cross-border cooperation across research, policy, and development activities. To realize this vision, we've designed a practical model for collaboration. Building on the value proposition, we propose a Nordic model built on 3 components, unified by a central coordination mechanism we refer to as the driver. The model aims to transform individual national capabilities into an integrated regional advantage. It should facilitate harmonized collaboration while upholding high standards of privacy, ethics, and scientific integrity. Each component connects specific stakeholders, creating opportunities for collaborative dialogue on shared health data challenges. The model rests on 3 fundamental design principles that apply across every component. First, to coordinate existing services, create connections and share knowledge across borders rather than duplicating existing national services or replace what's already working. Second, respect existing national mandates. It should not make binding decisions for member countries and should not replace national regulatory authorities. Third, all components should build on emerging EHDS infrastructure, ensuring that Nordic coordination leverages rather than conflicts with European requirements. So the Nordic model should focus on strengthening and coordinating existing infrastructure and look at how we implement the systems we're required to build anyway in the most efficient way. The knowledge sharing on systems and structure component should address the varying approaches to health data governance across Nordic countries, coordinating policy and regulatory harmonization while respecting national mandates. This component could build on the Nordic EHDS2 Competence Forum, where policy and governance stakeholders could develop a shared understanding and common approaches. The research collaboration and statistics component should facilitate cross-border research coordination while avoiding duplication of existing national research support services. This component would primarily facilitate coordination between national organizations, research institutions, statistical bureaus, and research funders. It should build on mature Nordic cooperation mechanism and focus specifically on health-related statistical collaboration and supporting development of comparable health indicators across countries. The innovation and industry component should create structured channels for industry and innovation engagement, with a focus on facilitating knowledge transfer about successful commercialization strategies and address the varying capabilities across Nordic countries. The component should aim to complement rather than compete with other innovation agencies, with its unique value lying in cross-country coordination. The driver is what makes it work, providing the essential coordination that transforms the 3 components into an integrated ecosystem, ensuring strategic alignment, coordinating shared infrastructure, developing performance metrics, and maintaining the ethical standards essential for public trust. The driver is the operational backbone of the Nordic model. It should ensure that everything stays aligned with the broader goals of Nordic health data collaboration and the EHDS. The driver should be responsible for facilitating alignment between the components' activities of the Nordic model, coordinating shared infrastructure, optimizing investment across participating countries, and ensure efficient allocation of both financial and human resources. Develop clear metrics to assess the model's effectiveness and monitor progress towards harmonization goals, and ensuring broad participation and legitimacy through ongoing communication with key stakeholders. In practice, the driver should, for instance, host regular hybrid meetings, allowing continued coordination across countries without travel demands, organize annual events that would rotate among the Nordic countries, bringing everyone together for high-level planning and relationship building. Arrange task-focused working groups addressing specific challenges, operating with defined mandates and timelines while coordinating with existing Nordic working groups. Actively involve citizens addressing concerns openly through consultations or public forums built on Nordic democratic festivals. This would provide both a structure and the rhythm that make this Nordic collaboration operational, inclusive, and sustainable. The benefits are realized through this coordinated ecosystem where data is generated by society through healthcare systems, patients, and citizens, and the generated data feeds into the component of the Nordic model. These components work together through coordinated Nordic efforts to deliver improved outcomes across multiple dimensions. The Nordic model envisions generating both improved public health outcomes and economic benefits, including reduced healthcare costs, higher productivity, and stronger innovation ecosystems that attract international investment and fosters new partnerships. This ecosystem would generate value for different stakeholders. Government would gain value through coordinated policymaking and enhanced regional evidence. Industry through partnership opportunities and support of simplified market access. Researcher through easier access to larger data sets and streamlined processes. Healthcare systems through evidence-based improvements that are validated across multiple contexts, and citizens through improved health outcomes, transparent government, and meaningful participation in decisions when it comes to collaboration and secondary use of health data. The main aim of the proposed Nordic model is to strengthen and better coordinate existing institutions and groups. This would leverage established relationships and existing mandates while adapting them for enhanced health data collaboration within the EHDS framework. Within this vision, the model builds naturally on institutions already operating at multiple levels across the region. The first steps in implementing the proposed Nordic model would be to find and establish a suitable driver. This could build on a three-phased approach that demonstrates value before requiring significant commitments. The first phase could be to map out all of the existing Nordic institutions, working groups, and committees and their capabilities, mandates, and potential contributions to health data collaboration, followed by development of coordination agreements and clarification of their roles. For example, here's a map of the Nordic Council of Ministers, institutions and working groups that relate to health data. We can assess how to optimize the structure of the Nordic Council of Ministers to better serve today's stakeholder needs. Institutions that were created at different times could perhaps be optimized and made more efficient if they were to be combined or better aligned. The Nordic Council of Ministers could potentially serve as the driver, with existing institutions like the Nordic Welfare Centre and Nordforsk taking on expanded coordination roles. This approach aims to better connect what already exists instead of creating new institutions requiring only modest budget increases for coordination activities. Phase 2 would then take the assessment of Phase 1, pilot it, and evaluate the outcome. If the pilot in Phase 2 demonstrates value, then in Phase 3 it would be implemented. However, if the pilot in Phase 2 does not demonstrate value, we would need to go back to Phase 1 and assess again potential opportunities. Our immediate priorities are clear: gather stakeholder feedback, coordinate EHDS implementation, define success metrics, and ensure sustainability. So, thank you.
Thank you, Rebecca. And indeed, the immediate next step is to gather feedback from stakeholders. And to do that, we have a panel moderated by Sigga and with Marketta Lilleström, Nicholas Godlet, Bost, and Julius Judakis as participants. So Siga, please come on stage, and all the panelists as well. I think this chair is for the moderator, and
Yes.
the rest of you are free to sit wherever you want.
So not in the order.
You can still stay within the order.
Well,
We trust the audience to be able to tell who's who.
This is personality test.
Yes. And do give them also.
Yes, and thank you. Thank you for the introduction, and thank you, Rebecca, for a very clear presentation. And I now hope that you all know more about the Nordic model for secondary use of health data. Thank you, panelists, for joining. We have your names up there, and we have carefully selected you to give feedback on this vision we have presented in the Nordic model. And I would like to thank you for taking the time to discuss this with us and give us feedback. You saw that Rebecca had a roadmap, a very broad roadmap at the end of the presentation, and this is actually in the report that will be published soon. It's the first steps we are seeing towards trying to operationalize the model. Where can we go from this idea, this vision? It's not an easy task, so we really need help. And before we go down that road, we would like to ask some important questions, perhaps fundamental questions. And the first one is, why is Nordic collaboration on health data important? Why is this the right moment to do something about strengthening our cooperation? And I'm going to start with you, Nicholas, because you were with Novartis. And we know that Novartis has a specific focus on Nordic collaboration. But we also know, like Rebecca said, that many innovative companies where health data play a key role find it challenging to work within the Nordics and look towards other countries with perhaps less strict data protection requirements. So if I ask you, what value do you see in working with the Nordic region that makes it worth navigating these complexities?
Yes, so first of all, thank you for including me in the panel. Yes, we are working Nordically on health data, and we're actually investing a lot, both in terms of people and activity budgets, to kind of look into what we can get out of the Nordic health data. I think it's unique, right? I mean, it was mentioned in the previous talk as well. I mean, we have longitudinal data sets. We also are 4 countries with universal access to healthcare. So the data in our national registries are really representatives because the whole population is in, right? And then we have the personal ID number making tokenization possible, try to link the different data sets together. So that's truly unique. And we're trying to, build projects around that. We are doing some multi-country projects, and we face the challenges that you, I think, nicely presented around timeline complexity. I mean, and then we had, it took longer time, but we achieved it. For instance, we built a huge database in asthma across 3 out of 4 Nordic countries a couple of years back, but that was a multi-year project. So it's possible, but I think the challenges are definitely there, and I think we'll talk more about it during the panel discussion here as well. But in general, I think, health data is underutilized. I think I read somewhere, it was a Forbes article last year, saying that 1/3 of all the data that exists out there is health data. And health data grows double-digit every year, right? It's the most rapidly growing data source is from health. And it's heavily underutilized, right? And also for industry, heavily underutilized to drive efficiency all the way from early development to more late phase, as you mentioned, innovation entrance, and how to make sure that right innovations are introduced into the healthcare systems to drive efficiencies and value for the society. So we strongly believe, and we try to advocate Nordic data also upwards in our organization. And there's huge interest. As a company, we're spending roughly $12 billion in R&D every year, right? And an increasing portion of that is within real-world evidence. And this is increasing. So I think there's a big potential to use Nordic health data much more. But we need to address some of the kind of the challenges that we see today, of course.
Do you think, can you use the Nordic data more? Can you answer more questions compared to using data from somewhere else, the US? Or?
Yes, absolutely. So I think what happens today is usually that, what we usually have in the industry is that time is everything, right? So we need to have access to data in time. We cannot wait. So then usually what happens, at least at headquarter level, is that you look into other sources. I mean, the US has built some good databases. I mean, it's claim databases usually, Flatiron and so on, right? But then you can question the representativeness, right? Because this depends on where you work. It's a selection of population, but here you can access data really quickly. So they use those type of infrastructure more. So I think that's kind of the trade-off, because you cannot wait. So again, the potential is super big because our data here is super solid, right? Even though the population is not big, it's very representative. It's fully representative, right? So the value is there, definitely.
Good to hear. So time is of essence. That is something we need to figure out how to change. If I turn to you, Julius, you are from Lithuania, right? And like you heard in Rebecca's presentation, we outlined the Nordic model, but we wish to expand to the Baltics. Do you see value for the Baltic countries to collaborate with the Nordics when it comes to secondary use?
Yeah, absolutely. And I think that's the only real way how we can have EHDS at this point is through these more localized regional collaborations. European Union is a very diverse place with many heterogeneous healthcare systems and different kinds of data, and not even all the countries have fully digitized systems at this point. So we can't just expect to have a regulation and that the next day we'll be able to share data on a similar basis freely. So it will undoubtedly need to arise from these more localized, more regional collaborations. And I think it very much makes sense to include Lithuania with this Nordic model, because we also have personal IDs for unambiguous linkage. We have national coverage databases with basically 100% population coverage and fully digitized EHRs. We have things like local laws that allow us to link different databases and to provide this data for research and for commercial uses. So I think we are at a similar level of maturity with the Nordics so that we can ask the same questions, and we have now the same issues that we need to move on next. So it does make a lot of sense.
Mm-hmm. Okay, so you have the infrastructure and maturity that is similar to the Nordics. And do you think it's important to take a look at it from a regional level, because this is a process? Is that what you're thinking?
Yeah, and again, the healthcare systems itself, it's very important that the healthcare systems would be comparable, because if you use data from the US, is it really that useful for us to analyze the market in Europe, in let's say Eastern Europe or Nordic countries? So it makes much more sense to focus on these geographically proximal regions and then build up from them.
Okay, good to hear. Okay, Marketa, you can bring us the patient representative. And why is the Nordic model for collaboration important from a patient and perhaps cancer research, because you're connected to that as well, perspective? What benefits can you see in Nordic health data collaboration from the viewpoint of patients?
Thank you for the question, for the invitation, and also involving this patient perspective. Before I start, I have to say that I work at a cancer research project, but I am not a scientist myself, so these views are really from an interested citizen point of view and patient point of view. And in a way, being a patient in a panel, in a room which is full of past, present, and future patients, like all we are, I think, is part of our human existence. This is a challenge, but I will try to be the voice of all of us. But in a way, if we think about collaboration and data and cancer research, I think for patients, it's also it's a ethical imperative that the data is used to get the solutions that they very much need. And about the international collaboration, like our societies, like ourselves and this event, patient networks are no different. They are already international on very many levels, and patients can find peer support from around the globe, or there are all these international patient organizations, networks discussed. They hear about research that has been done or is being done somewhere else. So it's very much like I don't think it's such a weird idea to do research, international research. And also I think it might be even surprising for many patients to hear about this difficulties researchers face with data sharing and cross-border collaboration. So I think for patients, we have the trust in the bright minds of you to solve these things and get things done and get the research done. But then again, if we think about international collaboration, we know this from many surveys and publications, is that many citizens or patients might be more comfortable sharing their data locally, very close to where they are treated, or the local hospital, or nationally. And the further away you go, when the data leaves the country, when companies are involved, that's when all the questions start to arise. That can we trust the other authorities in other countries? And for this, I think Nordic collaboration is a lovely test bed, as the societies are high trust societies still, and sort of the similarities and the kinship is there. So even those who are worried, I think, is a shorter leap to share data within the Nordics or other neighbors.
Yeah.
Almost Nordics.
Almost Nordics.
Yeah, it's a good point you raised about the international perspective, because it's maybe quite different to trust your local authorities or your researcher in your own country for the data. So if we think about that and try to move into the barriers that might be ahead and explore them a little bit, and you raised this concern about the international perspective, what think you can be done to just make sure that we maintain the patient trust, because the patient trust is the cornerstone of utilization of the data. What can we do when we're moving into this direction of utilizing data across borders?
Yeah, I think I like this question, and especially for like how to maintain the trust, because I think trust cannot be taken for granted. And especially like in Finland, we see the first signs with the healthcare reform now, with the budget cuts. There are these voices, worried patient voices, asking whether we can trust in a way that we have been trusting our healthcare system, for example. And we don't want that to spread, right? So that's the important topic. And then trust in itself is a positive thing, but in this context of data sharing and in the eyes or ears of a patient who's maybe very worried about their health and their life and whether they survive and all of that, that trust can also have a different ring to it. And I think in patient involvement circles, what is discussed at times is it really trust that we need to concentrate on, or is it more that how do you, all bright minds, can build these systems so that they are so transparent that the benefits for patients are so obvious that actually the trust builds on that and is a sort of a result of that. So that is something I have been thinking about, and also because the secondary use is so different from what citizens are used to nowadays. When we on daily basis we accept cookies and we give permissions here and there, and our consent, biobank consents and whatnot. And this is happening in the background. And this has been my small talk topic lately, that I have asked people that, hey, by the way, have you heard about secondary use? And I'm worried that so few have. And when you start to talk about it, they're surprised. They're not necessarily very happy about it at the beginning. And I think this is a challenge for us, the how to make this secondary use part of like the health literacy of citizens, so that we could break that sort of feel of secrecy in a way, so that people would know more about the secondary use, understand it more.
I understand. So information and transparency, that is what we should be working on. That should build trust. Would you like to add something? Is that something you think about?
Absolutely. So I just maybe want to comment first on, because I think there's a high trust to our health systems in the four Nordic countries, and the official bodies and so on. I think that trust also is something that, when you give the data away as a citizens to registries, there might be an expectation also that that data is used for the good of that country, right? To development of healthcare or insights in public health or and so on. So I think that's also a part of it, that it's important that these data are actually used to the better of something, right? I think there's a kind of an expectation when you also deliver data to as a citizen. And then as a company, of course, that's extremely important. So, I mean, for us in the Nordics, we never get access, of course, directly to raw data. We use, usually we collaborate with CRO companies and so on, so we get aggregated results to us and so on. Everything is obviously anonymized and so on, so we follow, of course, the regulations. We're completely dependent on that trust also to be able to maintain that kind of work, obviously. So that's very, very important. But I think there's a part also of not using the data. I think that is important to capture. That I think it's important to to really utilize the wealth of health data that we have to drive more efficiencies and value into the healthcare system, because all our countries have quite stressed healthcare systems, right? There's a lot of funding to it, but the need is increasing, and there's a lot of potential to drive maybe more efficient way of working, or many projects on that as well. And then the key to that is really understanding the health data that moves into the system.
Okay. Julius, is that something you think about in your institution in Lithuania, trying to give out the information about the use of the data and how it benefits society?
Yeah, absolutely. And I think more broadly, the EHDS model and, having a clear national law for data access model, that increases trust by showing, at the very least, by having one clear resource, one clear list of all the projects that are using patient data. Because, secondary use isn't, new, isn't coming to play only with EHDS. And if the people don't know about it yet, their data is already being used, but it's being used directly by direct agreements within hospitals, within biobanks, within registries, and other companies that are accessing data from those registries directly. By making this into a more transparent, more legally, maybe bureaucratic, but a more transparent pathway for the patient, for the data subject, I think we're letting them know in a more open way for what purposes the data is being used, for what price is the data being accessed, who is accessing the data, and what benefits they are creating with that data.
Yeah, exactly. Like you said, that's an important part of the EHDS regulation. This transparency, Okay, I wanted to ask you also, Julius, I believe you have experience with cross-border projects. What do you see as the biggest operational barriers in such collaboration?
Yeah, I think at this point it's very important to more precisely distinguish between different levels of collaboration. So we've already seen in the initial presentations today the federated learning model, where the same person only applies for data sets within different, let's say, HDABs or data access bodies, and only aggregates the conclusions. And I think for this kind of analysis, we have zero barriers today. We can do that, and I encourage everyone to, today, tomorrow, make an application for Lithuanian data as well, compare how it works, in contrast to the Nordic data models, and we'll have these pilots and we'll learn from them. And we already have, local branches of Novartis, local branches of IQVIA using our data and making conclusions from that. So I think we have zero barriers for this kind of collaboration. But if we want, like in VALO 2, where we want to bring data sets together into one SP, if we want to try out the EU level data access applications, that's a much more complex collaboration model. But again, we have to try and we have to see what fails, where are the points of failure, so that we could try to fix them. It's very hard to solve these issues in the abstract without having tried.
Yeah. Okay, I was thinking about you, Nicholas, as well. Are there any friction points in cross-border cooperation that you would like to mention specifically?
Yeah. So we've seen that, obviously. So I think one of the key points is maybe, I mean, when we move into new areas, for instance, as a company, we would like to understand how is this disease handled in our countries today to understand, the disease landscape. And then we would like some, usually it's pretty basic data, right? It's, when it's diagnosed, set, what kind of treatment, how is the patient flow and so on going on in the 4 countries. So we have the same questions usually for the 4 countries. And then when we kind of are asking to access those data sets, we see 4 very usually different ways to those data. Some countries are handling it in one way, maybe for that specific project quicker. For another country, it can be very lengthy. Sometimes we also get a no. So it's sometimes very unpredictable. And sometimes we are also, and this is, I'm not a lawyer, so I cannot say, if it's different laws or anything, but we get the sense that sometimes the same law is interpreted differently also among the 4 countries, and that creates some unpredictability at least. And that's maybe so one thing is long time to data. That's not good, but the worst thing is unpredictability for us, because we would, if we even knew that it takes 2 years to access data, and that's a predictable timeline, that's long, but it's better than suddenly doubling the time to 4 years, right? So that unpredictability that we sometimes see, that's maybe the worst part for us, and creates sometimes a lot of challenge. And then we try to, of course, understand what drives this difference, because we are under the same EU laws, for instance, all the 4 countries, and why do we see these differences in the countries playing out? And why I cannot answer in detail, but probably maybe it's interpretation. I don't know, but there are some country differences there. The other difference we also see is how these cases are processed. In some countries, it's a dialogue with with the data requester, and sometimes that dialogue can lead to, okay, we understand that accessing all these variables makes it difficult, so we can remove some. We can do risk minimization because these are the critical ones, and we have a dialogue. And that dialogue happens efficiently, and then we reduce the time. In other countries, it's more, we give an application, and then we get an answer back, no. And they, oh, okay, so could we have solved this by having a risk mitigation dialogue, right? So these are also different ways of approaching this that drive some differences. There's some frustrations from our side, but I think with all the work ongoing now in the 4 countries and all the emphasis on this and the Nordic model and all the ambition around this, I think we're positive that this will change. But I think we need to understand these, it's sometimes small things, right? But it actually matters in each of the cases and creates, in some cases, big country differences. Yeah.
Okay, it's good to hear you say this, because we were discussing this application process yesterday in our competence forum, and we know that 2 countries are now using this, having a dialogue before you apply, before you send in the application, to do exactly that. How can we make it so that this is an application that can work? That's a very good idea, and we are thinking about, working further on that, so we can perhaps harmonize in the Nordic countries how we do this and use experience from each other. Okay, that's great. I would like to move on to the Nordic model and ask you what would make the Nordic model for collaboration work for you. And perhaps if I just start with you, Nicholas, we know that the EHDS legislation brings certain benefits, but what would the Nordic model specifically add that would make it valuable for Novartis to commit to such a network? Because we know that time is of essence, and you have to get something out of it to be willing to participate, give time in the cooperation within the model. So what would be, how can you see, what benefits would you like to see from participating?
So I think disclaimer is, of course, that I understand the model. It's a bit theoretical still, I think. I try to grasp it every time I see it. What does it actually mean? I think it describes maybe the kind of the partnership, the right partners, as I understand the model, are kind of in the ecosystem. I really like the part about, trying to harmonize, share across, with the previous discussion we had around, the country differences. How can we understand and maybe overcome and harmonize also the actual approach more. And then I think, industry was on market access, and that's true, but it's also research, right? So we're doing a lot of research, and I think we're sitting in Finland now, and our early research department at Novartis has a collaboration with Finland, right? So I think the industry part, or the research part of industry is also, I think, an important stakeholder to take into account. So it's not only the access part. I think also the early research investment and collaboration, that potentially is huge. Again, to the richness of data and also biobanks that we have in the Nordics. So I'm very optimistic to the model. I think it really gathers the partners, and then of course you need to have the right sponsors behind, because sometimes maybe there are some heavy lifting needs to be done, either to allocate resources or investments, or also maybe you need to harmonize laws, maybe in the countries, do some changes in laws, and then so you need the right levels also from a sponsor standpoint to be key enablers to make this work. So that's maybe, I'm not sure how, but that's maybe the driver. I'm not sure in the model here how that is captured, but so I guess that's based on my understanding of the model right now. Yeah.
Of course, I understand, and I understand it's a bit theoretical still, although we are trying to get it towards more practical. But it's good to hear you say key enablers, because what this really is, we are creating networks of networks, and something to drive this. And from the network theory, we know that it's important to have key enablers. So I think it's a very good point that you mentioned this, and this is something we need to think about in the way forward.
Can I just add one thing? Because I think what you've done really, really good in Finland when you built your local health data ecosystem, you had industry around the table from the very beginning to understand the need and what because I mean that's kind of that's a different end user than academic research. I think there are different drivers there. So that's a part that I really like in the model. That's industries in, because I think that's to really tailor-make something that also fit industry need all the way from early research to more late stage.
I'm thinking about you, Marketta. Again, if we look at the Nordic model of cooperation as a tightly knit network of stakeholders that interact on a regular basis and get something out of this network and interaction, what would be a meaningful patient involvement in this network? How do you see that? How can the patients groups meaningfully involved? We're not just saying you're there, you're presented, you're actually members and contributing.
Yes, thank you. That's also something when I was listening to the presentation and seeing in one of the figures, the driver and the innovation and research, and then the citizens and participants, patients kind of hovering around it. And I think the common frustration for patient involvement enthusiasts is that if we settle to listening to patient voices, so it's an easy way to kind of make a survey, hear about all of these ideas, but if it's left there, if patients and citizens don't see the impact, then it's kind of feels a bit of a token, right? So this is something that it's not easy to solve, especially with the secondary use, because the wheels are in motion. We cannot change everything to match the wishes of patients who would oftentimes like to have more visibility to their data, to get access to what is the innovations that are sort of built on their data. For example, my data is used in FinGen. I heard excellent presentations of some studies that I kind of think I am in, but I don't know what it means for me. And that is kind of when we think of the common good and when we talk about data altruism, I think it wouldn't hurt to think if there are ways to accelerate this, to get the benefits for the patients whose data is being used. And we are working with the biobank to see how we can return the data, the research data to the clinics already during the project. And I would like to see things like this happening more. And I think that would also be good for the trust part and make people like to see what is there for them, and it will be according to values like the democratic participation and all of that. So I would like to see this model to have really like ambitious goals and show the way and show the light, so that when the Europeans or all of them we need to work together. So we could be like a model in that sense as well.
Thank you. I know it's not an easy task.
No.
We will continue to work on this. And finally, you, Julius, what is the value of the Nordic Baltic 8 steps aligning now rather than waiting for the EHDS implementation? Or,
To be very short, I'm again pitching my main topic today, that it's, I think, real world piloting of these processes is the main value, because for us in the public sector, it's really hard to iterate on our processes. We can't change laws easily, we can't change budgets easily. So we need to try each other's solutions, see what works, see what doesn't, learn the lessons and, take it from there. Otherwise, it's a very abstract thing that can turn out very wrong in the end when we bring it to practice.
Thank you. A good point. Real world piloting. We heard about one pilot this morning, and then another pilot is in preparation, so that's good. So we only have a couple of minutes left, but I would like to ask you all, just for one thing, if you could prioritize one thing that needs to happen with regards to Nordic cooperation and therefore perhaps the development of the Nordic model in the next year or so, what would that be? If I start with you, Niklas.
Yeah, 1 year is a short time. No, but I think it could be super good. I mean, it's basically maybe what we see today, but I have a really strong commitment from all the 4 countries, and that you have the key enablers to make it happen, that everyone is on board, right, in this ambition. I think my impression is that Finland has been really a front runner on this. So how can you bring all the 4 countries up to the same level of commitment, and having also the local key enablers, ready to deliver on that. That would be, but a year is maybe not long enough. I don't know, but.
Thank you. And Marketa?
Very difficult question from the patient perspective. I don't know whether this is answering the question, but wouldn't it be lovely if we had within a year an interface, patient accessible interface where they could see the data, where is it used, and so on and so forth. So not answering the question, but adding one more thing to the to-do list.
Thank you. Julius.
And I'll just repeat again, piloting, as many real attempts to use data as possible. A year is enough time to do 5 different data applications, receive the data and analyze it and get the results.
So, okay, we're approaching the end. I want to thank you all again for participating. And I'd like to remind you that we have VALO 2 for a year, so we can really continue to work on the roadmap that we will do, and we'll really put our efforts into trying to operationalize the Nordic model. And like Rebecca said, we will try to identify the building blocks we already have in Nordic collaboration. It's important that we use it and try to align it what is going to happen in the future. So with that, I also thank you for listening and encourage you to send us comments and feedbacks whenever you like. We really like to hear your voices. Thank you.
Thank you.
Thank you very much for the panel. Time, money, trust, sounds familiar.
And that's it for the first third of this event. So this has been the kind of green shirt VALO part, and now I'm handing it over to the blue-pink FinHITS part. Before doing that, there was at least one question in the chat regarding federated use of secure processing environments. That was for the panel. The panel earlier didn't have a chance to answer that question, but yes, in VALO 2 project, the pilot is really about federated or at least distributed use of secure processing environments. So how one researcher in one of the Nordic countries can enter secure processing environments remotely in other countries and make studies there. So that's our kickoff. We'll launch VALO 2 right now, and let FinHITS take it over.
Thank you. Next, I have the pleasure to introduce my dear colleague. She's been working at Findata for many years, first as a senior expert, then as our development manager, and for 2 years she's been leading the EU direct grant project FinHITS. So give a warm welcome to Mari Parkkinen. Oh, there she is.
Okay. Hello, everyone. Thank you, Antti. I'm Antti's colleague, Mari. As Antti told you, I've been working for Findata 5.5 years now. First being part of providing the services, then now as development manager. And I think my perspective is very practical one. Antti asked me to tell you more about the FinHITS project, what are our goals, what we have done this far, and what we are going to do next. And I'm following his guidance and will do that. First, I'm going to give you a little bit more information, background information on Findata, and I hope this will help you to grab and get an idea why we are now implementing FinHITS in the way we are. Yes. Well, first, Findata. What is Findata? Findata is a centralized data permit authority for secondary use of national social and health data. We were founded in 2019, and our operations are based on the National Act on the Secondary Use. We are in many ways similar to the so-called health data access bodies, that operations and responsibilities are described in the European health data space legislation. And also our National Act for the secondary use was used as one of the kind of background materials when EHDS regulation was written. So there are many similarities between these two. Our mission is to improve access to rich nationwide data sets and enhance data security and data protection of individuals. In some cases, when we develop our services, these are something we can do simultaneously. But as you can imagine, in some cases, we balance between these two. How do we facilitate the access to data, but still make sure that the data of the citizens is kept safe and secured, and this is respected? We provide access to data from national registries, public and private social and healthcare service providers, and Kanta services. We are positioned in the Finnish Institute for Health and Welfare and steered by the Ministry of Social Affairs and Health. We are kind of an independent unit in the institution. We have our own budget, and we have independent authority on decision-making related to the data access. And the reason is that it wanted to be make sure that when we are deciding on the data access, we are not the data users, but there's a so-called firewall between us two in this sense. Findata's core services also resemble those of the health data access bodies services. We give help desk services to help applicants to understand the secondary use system in Finland and understand if the permit is needed from Findata or from somewhere else. We also maintain metadata catalog in collaboration with the Institution for Health and Welfare, and train, for example, data controllers on describing their data sets. We grant access to data and provide aggregated data, so we handle the data access applications and data requests. Once the decision is made, we collect data from multiple data controllers and pseudonymize or anonymize the needed data for the data users. And as in our case, there are many different data controllers the data can be applied from. Sometimes managing the collection phase might take some time. For example, when the target group is extracted from one data controller, the other extracts the controls for the target group, and the third one, the whole data set. We also provide Kapseli, secure processing environment. Kapseli is one of 10 audited secure processing environments in Finland. They are audited against the regulation given by Findata that bases on the National Act on the secondary use. And at the moment, when data is provided by the data permit, it can be only handled in one of these 10 secure processing environments. And as they are all in Finland, the data, there's no possibility to take data out from Finland at the moment. We also provide transfer services, so we make sure that this data is collected and transferred through the secure services. Here are the use purposes of the current National Act. For individual level data, data can be extracted for scientific research, statistics, planning and reporting duties by authorities, and teaching. For knowledge management, the data permit is not needed. So data controllers can use their own data on the purpose of knowledge management. For aggregated data, the data can be gained for development and innovation activities and knowledge management when the data is used from the multiple data controllers and steering duties of authorities. And as you can see, these purposes, they have also some similarities with those listed in the EHDS regulation, but they also slightly differ. FinHITS project started 2 years ago, and we have 2 more years to go. We gained funding. We were nominated by the Ministry for Social Affairs and Health to apply for the funding from the EU for Health program, which was meant for member states for setting up services by health data access bodies for secondary use of health data. And we applied this funding and we received it. And it's 60% funding with 40% coming from Findata's own budget. We are pretty much just in the middle of the project. And our objectives are strengthen the Finnish infrastructure to ensure efficient and secure secondary use of health data. As we already had some of the services on place, what were needed by the health data access bodies, we decided that this is our chance to further develop these services based on the knowledge we have achieved since we started and all the stakeholder needs we have identified. We also want to enable Finland to integrate seamlessly into EHDS. So prepare these services from the perspective of the European Health Data Space Regulation. And what are the key areas of development of this project? They are the help desk services, Findata's data access application management system, the national data catalog, secure processing environment, and building technical solution to connect the health data at EU infrastructure, and then promote the quality of health data, especially from the perspective of EHDS. Here are our principles on what we base our development work done in the FinHITS project. We, of course, been studying very closely the content and objectives of the European Health Data Space Regulation. In addition, we have done a lot of work to collect experiences, feedback, and ideas from the national stakeholder groups, as the efficient system needs to input from all of different actors. We also follow closely other EU projects. VALO could be also mentioned here. Now I see it's not. TEHDAS 2, Quantum, and we participate in the community of practice to understand what other member states are doing and collaborate and develop our services the same direction with others. And we have had some challenges from the project's perspective. First is that the project started before we knew the final content of the European Health Data Space regulation. And we still, as you know, we still don't know about the content of the implementation acts, and we still don't know how EHDS will be implemented in Finland. So, and the other is that there is an ongoing reform in the national legislation. And as we in Findata, we follow closely and we provide the services based on the legislation. This is always our first priority, to be in line and to operate as it is described in the national legislation. So possible reforms will take our resources if we need to align our services. Here's a timeline. Here you can see that the first kind of phase of this project was to define requirements and technical specifications for these key development areas. And as we already had some of these services in place, we also wanted to pilot and build the minimum viable products as fast as we can to learn and maybe then come back to defining the requirements. So we've been doing this two phases simultaneously. As well as we have services in place, so we also wanted to deploy the solutions once they are ready, so that we can also collect the feedback and maybe further develop them during the project. Here's our stakeholder, how we want to collaborate and hear and collect the stakeholder needs. First of all, we have advisory group that contains some representatives from the key stakeholder groups, from the ministry, and from Sitra. And we meet with them 3 times a year. We present what we have done, and we ask their opinion. We tell what we are going to do next, and we discuss these things together with them. And this advisory group has been very important for our success, and we have found the collaboration, this close collaboration, very fruitful. We collect feedback with 3 satisfaction surveys. One we have completed, one's going to be this year. I hope all of you who use our services will reply to it. And we're going to have one by the end of the project, so that we can see what is the satisfaction rate and which way it is going. We have had, in the beginning, we had this kind of kick-off workshops where we discussed even deeper level how the current services are and what are the possible needs. Now in the middle, we have this FinHITS forums concept where we present the work we have done, collect the feedback, in some cases provide possibility to test our services and again give feedback to us so that we understand what are the thoughts of our stakeholder groups. And then by the end of the project, we are going to have, of course, an ending seminar, but also more and more education and information on the developed services. Here's the expected results for all of those 6 key areas of development. First of all, with our help desk services and training, we have had a pretty great help desk services thanks to Antti and all the Findata stuff. And now in FinHITS project, we've been further developing it, especially from the perspective of international applicants. We think that when the EHDS it will grow the amount of interest in the Finnish data, also for sure for the Nordic data, And in this case, it's more and more crucial that people that are not Finnish understand how, for example, our health system is built, where the data can be gained from, what kind of data that is, and so on. And we've been, since quite the beginning, we've been working hard to help our applicants to submit applications that have all the complete information. If it's not, we will be all working around that application. So we've been continuing that work also to bring different ways to gain that information. For data access application management system, during the application phase, one of the crucial things is the collaboration between the data user, data holders, and Findata, so that data users are able to describe the needed data sets in a detailed enough level so that the data controllers know and are able to extract that data for the data user. And in some cases, this takes time. And here, what we are doing with our current e-service, we want to improve it so that the applicant could describe the data digitally in our e-service, and that they could use directly information coming from the metadata catalog, so that we could use the same information that is provided in metadata catalog. At the moment, there's no connection between these two solutions. And we also want to facilitate the communication between data users, data controllers, and Findata. And we see that this will help, of course, the application phase, but it's very crucial also for the data collection phase, so that the applicant will receive the data that they were thinking or applying for. For the national dataset catalog, we want to improve the user friendliness and enhance the discoverability of the datasets. And at the same time, we'll start to prepare it for the its standards for coming. We're preparing it to EHDS so that the structure would follow the standards given from the European Health Data Space Regulation. For the secure processing environment, we've seen the tendency, the data that is applied grow. And by the time, larger and larger data sets are needed. And one of the difficulties here has been transferring that data and having the capacity for the data users to use that data in our secure processing environments. We are working on that. And in addition, we want to be more efficient with checking the anonymity of results, so that data could be also taken out faster from Kapseli than it is today. With cross-border data use, where our plan is to build a technical solution for health data at EU infrastructure. And the last, data quality. Here we call it there's a kind of two tracks. First, we're gonna form two ready-made data sets to facilitate reuse of the data. But also, on the other hand, we are preparing for the data quality work coming from the EHDS that is not so familiar to us yet here in Finland. Here are some key achievements this far. I'm going to show you the photos because I can see that my time is running. So to show you, instead of talking you through it, here you can see our personal consultation service, free of charge, 20 minutes. You can reserve time with Findata's experts. We have a new training portal that includes training especially meant for the international applicants. We have several videos explaining the processes to help our applicants to understand. Data assistant to help our applicants to find under which data controller might be the data they are needing. And we have chatbot called Vinkkeli. If you're interested in these services, we have a pop-up in the second floor with Findata staff there that are able to explain and actually demonstrate these services for you. And these very people have been also developing this solution, so I warmly recommend you to go and talk with them. There's a first version of improved e-service that was tested by Findata and stakeholders. We know that there's still much more work to do, but the first minimum viable product we were able to provide. We have launched 2 new services. We have Supertunneli for large dataset transfers, and we are now building the connections to the data controllers and SPE providers. We have Portti, which helps us to be more efficient with checking the anonymity of the results. What's next? We have a lot of things coming up, 2 more years to go. New courses in the training portal. We're gonna hold campaigns for citizens' awareness and trust. We're gonna pilot our new data access application management system together with our true clients. We have first FinHITS forum on national dataset catalog and the improvements that have been done there during this year. And the planning on implementing Health DCAT AP mapping in the national catalog will start. There's the secure processing environment. We're going to have a working paper on federated computing. We've been studying how this could be implemented and how should it be implemented. And we're going to have dynamic GPU and license management. We're going to start the actual development work to connect health data at EU, and we're going to have 1 more ready-made dataset to come, and we're going to start the actual work on data quality that described in the EHDS. Here are our upcoming events, and here's my last slide. I've heard a lot of discussion, and I think the similar themes are coming out from different speakers. But I think these are the 3 crucial cornerstones for implementing EHDS, and also to collaborate in the Nordic level. First of all, if we have no collaboration between data users and data holders and Findata, we will not have efficient processes. If our solutions are not providing like something better for all of those stakeholders, they are not good solutions. So the collaboration is very crucial. Trust. I wrote it in my hand because it was so well put. We can't take trust of the citizens for granted. I think Marketta said it. Yes, I agree. We can't take it for granted because if there's no trust, there's no data. And that's it. But I think building trust, yes, we have to show what is the impact of this. What are the gains of using this data? And we have to explain why and how we're going to take care that their data is saved and handled in the best secured ways. Third, agile operations. We are building something totally new here. We are doing something that we haven't done before. And in that case, it is really crucial that we, in addition to planning and implementing, we have to learn fast and do things again and focus solving the possible problems that are to come when we are implementing something such as European Health Data Space, which is a huge thing for all of us, and keep this kind of mindset. Okay, I think I run out of time. I thank you very much for your attention. I have to say that I'm very, very happy to be here today.
Thank you, Mari. I'm not going to let you go yet because we have short time for audience questions, and I know that we've already had some from the chat. But does anyone have any questions for Mari in this over there? All right, I think that was the first hand I saw. Okay, yeah.
Wait. I have a question regarding, as you mentioned, so you are positively very, you want to, like, after the implementation of the technical solution and then gather the feedback quickly to be very responsive about like new improvement suggestion. So my question is, okay, so from whom you're gonna gather this information? I mean, is this regarding like the Finnish like national data application portal, or it's like regarding like the working package with the EU EDA, the EU application portal, and also through which channel you can build this communication?
Feedback generally in the project, we've been collecting it in multiple ways. We have had workshops, questionnaires. We have this specific forum for discussing with stakeholders. By stakeholders, I mean mostly the national data users and data controllers, but we've been also trying to learn from international applicants and about their needs. We've been participating quite much in the community of practice and this EU project to also hear the thoughts of the other member states.
So for the stakeholder of the data users and either it's a public agent or the research institute, you have a community to communicate with them, like a forum or something?
Yeah, for the project, we have these specific events, but they are also in Finland, there's that are now in pause, but there's a steering group for the secondary use of social and health data. And there have been like the national working groups for customers, data controllers. And we've been, of course, also participating those working groups and presenting the work. So I think there's not one forum we'll be using, but more like multiple ways to connect and collaborate together with national stakeholder groups.
Yeah, and if any one of you have any special needs or feedback, you can always send it to me. First over there, and then here.
Yes, I'm Lilbrit von Arx from Eli Lilly. So just regarding trust, I'm behind here. Maybe I should just stand up. But you had trust as one of the 3 items of importance. But I'm kind of lacking actually a platform for how we share back the results of the studies that we do with patients. Because, for example, in the UK, the ABPI, so the UK Pharmaceutical Association, has created like a case library where we can share case studies on or examples on how we use health data, kind of to share back with patients and for them to understand the benefit of actually sharing health data. So that's one thing. And I also find that having a repository of what projects are being done, I'm actually not sure if Findata has that, like a list of what studies are, which studies that have been endorsed and which one are running. But I think that would be a way of promoting trust as well.
To answer your question, yes, we do publish all the projects that we have provided the permits for. That's, I think, been under Antti's desk.
Yeah, true, but they don't include the results of the studies.
Yes.
Which is something that we try to get from the researchers, but they don't always provide it to us. But I agree that there should be a platform, a transparent platform where all of the projects would be seen.
Hi, Karri Ankkali. So today we learned that VALO was mainly about harmonizing processes, but not yet harmonizing the data. And one of your major tasks is aggregating data, which is relatively simple. I participated into Health Design 2025 2 days ago. And one of the major challenges still is that data is in silos. Like we today heard, OMOP model is far, far, far from being ready, like episodes of care and so on. So how do you harmonize the data within FinHITS? What are your plans? And of course, to make the data also be more effectively used?
That is a very good question. Findata does not harmonize the data because we are providing the permits for the data coming from the data controllers. And in this case, they are the best ones to also provide, for example, OMOP data sets. There's a lot of work on this, for example, in the Institution for Health and Welfare, that are also, Gustav is better than me to tell you more about that, but planning to provide this kind of FinOMOP, so OMOP databases. Our job is to make visible what kind of data sets are available in Finland. And for example, information if the data set is in OMOP format can be found from the national metadata catalog.
Thank you. Any other questions from here? Yeah.
Yes, Christian from OMOP for Sweden. So building on that, do you see efficiency for your authority or your group if the data is harmonized towards OMOP versus if it's not?
I think it's more like if that data is described in the level that data users can use those descriptions when they provide data permits. For OMOP data, I think it's easier maybe for the international customers to use it. So in that sense, because our work is always depending on what kind of applications we receive and how knowledgeable the applicants are. So I'd say that yes, and no. Yeah. But I think for the international applicants, that is very helpful to have OMOP data sets available, so they don't need to use time understanding, for example, the very national coding, and we don't need to use time on finding or helping them to find information.
Yes and no. Did this satisfy you? Yeah.
Yeah. Hi, Lauren from ABN. I wonder, what about AI, the role of AI in checking compliance in your processes?
At the moment, we don't use AI for checking compliance. We have an AI-based tool for pseudonymizing unstructured data, and that's the way we're using AI at the moment.
Thank you, Michel Silvestri, Swedish eHealth Agency, and thank you for an excellent presentation, Mari. My question may sound like a compliment, but I'm actually curious for an answer. And I would say that Finland, and specifically Findata, is very often a role model. For instance, for us in Sweden, when it comes to secondary use of health data and these things, preparations for EHDS, etc. So my question is simply, where do you get your inspiration from? Which is your role model? Do you perform some kind of specific horizon scanning for these issues that you need to solve, etc.?
I think this answer depends on whom you ask from Findata staff. I personally get my inspiration from the ways that data can be used, the possibilities that is provided, and also from Findata staff. I really wholeheartedly and honestly admire the people that are working in Findata with their efficiency, their focus, and the way they actually want to improve things and make their work as good as they can.
Okay, hey, thanks for the wonderful talk. It was very interesting. I would like to go back to trust. Actually, follow-up question on that. I was thinking that in order to have trust, there has to be something that we're trusting, and we have to know what we're trusting. So my enlightened guess is that Finnish citizens, they are not even that aware of the secondary use of health data. So what does Findata do in order to raise awareness of what we're supposed to trust?
Again, Antti asked head of communications is always also a good person to reply to this. But I'd say that we have very transparent, open, for example, guidance for citizens how they can use their rights, the GDPR rights. And we try to be very open. For example, we are publishing the list of projects that have achieved permit from us. So I think it was from you, Antti, you launched this saying that we keep everything else is open except for the data. So this kind of attitude also how we communicate.
Thank you.
Hi, Ornella from Success Clinic here. We've been using Findata since the beginning of Findata. But we've seen recently, especially this year, that the processes have changed and there have been delays in data delivery. Is it something to be expected, like moving forward, or you are testing some processes and seeing what works and what doesn't work?
We launched the Supertunneli, the new data transfer service for larger data transfers in the spring. We're now building those connections, so it will facilitate that. We've also seen that there are now more resources in our data team, and so it's like the work they do is more efficient than it was like a month ago or 2 months ago.
There's a related question online asking what's the actual timeline to get the permit. Can you give like the best outcome, worst outcome, and median?
I think somewhat 92% of the permits are handled under 3 months. It's maybe even more, 95. So pretty much all the data permits should be provided under 3 months timeline. I was just checking these numbers, but cannot come up with the exact numbers anymore. I think in the best cases, it's some days, and in worst cases, it's a lot longer. But if you apply data from us, you should be able to receive your permit well within 3 months.
Another very detailed question. How many permits has Findata granted since it started operating in January 2000?
I think 2,100 applications processed.
Yeah,
even more.
I would say a little bit less than 2,000 permits granted.
Thank you.
Yeah, no worries.
If there are no other questions from the live audience, there's one interesting from the online. So Finland has an opt-out model for secondary use. How many people have opted out from Findata? Do you have that figure?
I'd say it's something between 2,000 and 3,000. Maybe 2,500 would be my guess. I don't know the exact number either for this one, but it's not tens thousands of people and it's not hundreds of people.
And for reference, Finnish population is 5.6 million, and I'm actually not sure how that addresses minors, whether they can opt out or whether their parents can opt out for them. Or...
Their parents can opt out for them. Yeah.
Any other questions? We still have a couple of minutes.
I would have one from the chat as well, as there was already a question about how do we get inspiration. And I would say that one of the inspiration points would be our customers and data users, which have very many ideas, very good ideas, but due to resources and time, not everything can be done immediately. But I have a question that do you have API for submitting applications to your DOMs? Perhaps this could be transferred into question that have we thought about adding an API to our DOMs for submitting applications?
It's a good question. There are probably pros and cons. I think that would be an interesting idea to study further on.
Yeah. One final.
Not actually a question, but a comment. But you will have when you connect to health data at EU, then in the EU there will be the European Commission DAMS system, and then researchers can then apply directly from Findata. So that's basically an API integration then towards the EU.
Yeah, and the idea is to bring those applications to our case management system so that we could directly start handling those.
All right, let's get a round of applause for Mari.
Thank you.
All right, now to the hard part, conclusions. Do you have any?
No, I'm again ready for the main act, and that's the audience and lunch and networking and all of that. I think the discussion was good already, and we need to keep the energy going and discussions rolling.
Okay.
Do we want to go to the practicalities? One of the most important parts is that lunch is being served where coffee was served, but it's also being served one level up. So when you go up the stairs, you take right, and then go up again, and then you end up in this balcony that's surrounding this area, and there's another lunch line. So if you are able to walk 2 stairs up, go there. It's probably less crowded, and the food is probably much better there. Go upstairs.
And then one important aspect to our online viewers, that the stream is unfortunately going to end now, and the afternoon session is only for live audience. But very much thank you for all the online participants.
And
as well.
Sofia, who's been moderating the chat there, please copy the chat so that we can even get back to that later on. Not sure how long the page will stay open. If it stays open, we may even be able to answer some of online questions there. There were also questions regarding the other sessions.
All right. Bon appetit. And see you
and be
in
back.
an hour.